In this video, I'm going to cover the key concepts you want to know about fluids and electrolytes. Let's start with the basics of cell membrane transport. The human body likes to maintain a homeostatic environment to make sure that our fluids and solutes are equally balanced. And to do this, it has different types of transport processes that allow this to be achieved. So in this review, I'm going to be talking about the two types of diffusion known as simple diffusion and facilitated diffusion, along with osmosis and active transport, and hydrostatic pressure and oncotic pressure, also known as colloidal osmotic pressure. First, let's talk about the processes that move substances within the cell, specifically that cell membrane. Here you're going to see a phospholipid bilayer that is found within the cell membrane. And this phospholipid bilayer acts as this medium to really allow substances to flow in and out of the cell. So here you see the circular yellow little balls. Those are known as the hydrophilic heads, and then coming off those heads are the hydrophobic tails. And they really just come together to help form this barrier that separates the extracellular part, the outside of the cell, from the intracellular part, the inside of the cell. And then scattered within this membrane are these channel/carrier proteins. Now, one thing I want you to remember about this bilayer is that it is very particular. It only allows certain substances to go in through certain processes. So really based on the size and if this solute is charged will depend on how it's going to enter or exit the cell. So first, let's talk about simple diffusion. Simple diffusion is just as its name says. It's a very simple process because it requires no energy from the cell and it's a passive form of transport. So what happens with this process is that molecules, hence solutes, are going to move from a high concentration to a low concentration. So here we see outside of our cell a lot of solutes. There's a high concentration of them. And according to simple diffusion, they are just going to easily diffuse, hence move through that phospholipid bilayer to the inside of the cell where there's not a lot of solutes until homeostasis has been achieved. So this mass movement will continue until we have equilibrium, where we have a balance of these solutes. Now, an important thing to remember about simple diffusion is that only tiny non-charged molecules are going to be able to go straight through this phospholipid bilayer. So we're talking about things like oxygen, carbon dioxide, and so forth. Now, if bigger charged polar molecules want to move in and out of the cell, they need to do it through a different process known as facilitated diffusion. And facilitated diffusion is very similar to simple diffusion, but with facilitated diffusion, it's going to use these special helper proteins that are found within that phospholipid membrane to move these solutes, hence molecules, to and from the cell. So again, these molecules, hence solutes, are going to go from a high concentration to a low concentration. It's going to go down that concentration gradient. It's a passive form of transport, requires no energy, but it's going to allow big molecules that are charged and polar to move to and from the cell. They just can't go straight through that phospholipid bilayer. So we can move glucose and ions to and from the cell. Now we have a different type of transport that's sort of going to do the opposite of what diffusion did, because with diffusion we went from high to low concentration. We were going down the concentration gradient. It was a very simple process. We didn't have to go against it. But sometimes our body wants to move against this concentration gradient and wants to go from a low concentration to a high concentration. And this is where active transport comes into play. So with active transport, there's going to be the movement of molecules, hence solutes, from a low concentration to a high concentration through these special proteins found within that phospholipid bilayer, but it's going to use energy in the form of ATP. So here we have our phospholipid bilayer. Notice on the inside of the cell, we don't have a lot of solutes, but on the outside of the cell, we have a lot of them. So with this transport process, we want to go from low to high. So we're going against that concentration gradient rather than just down the concentration gradient. So when we go against it, it requires effort, a lot of energy. So this is where we utilize ATP. So in order to move this molecule from the inside of the cell to the outside of the cell. It's going to flow through this special protein channel, but ATP is going to help energize this process, and we're going to be able to flow to that higher concentration. Now let's take a look at osmosis. So with osmosis, we're talking about the movement of water. Water is going to move through a semi-permeable membrane that is only permeable to water and nothing else. And it's going to do this through a passive process. It's a passive form of transport, requires no energy. And the whole goal of osmosis is to achieve homeostasis in the terms of water. Water wants to shift around until we've equaled out the concentration of water inside and outside the cell, and we've equaled out that solute concentration. So whenever you're trying to understand osmosis, you can look at it one of two ways. One way is that you can remember that water will move from a high water concentration to a low water concentration, or water is going to move from a low solute concentration. So the solutes, hence the dissolved substances that are in that water, are low, and that water wants to move to a fluid, hence water situation, where the solutes are high. It has a high osmolarity. There's a lot of solutes in it. So water is attracted to solutes, hence water is attracted to sodium. You've got a lot of sodium on board, it's going to draw a lot of water in. So those are two ways you can look at osmosis. And when we're talking about a cell, we're talking about water moving in and out of the cell, and it all really depends on that solute concentration, whether it's high inside of the cell or outside of the cell. So let's look at this illustration. Here on the outside of the cell, or extracellular part of our cell, there is a lot of water, but there's not a lot of solutes. So it has a low osmolarity on that extracellular fluid. But on our inside of the cell, notice there's a lot of solutes, but not a lot of water. So it has a high osmolarity in there. So according to osmosis, effortlessly, no energy needed, that water wants to achieve some homeostasis. It's really salty or high osmolarity inside of that cell. So that water is going to be drawn through a semi-permeable membrane, and it's going to go and enter into that cell until it's tried to equal out osmolarity inside and outside of the cell. And whenever that's achieved, osmosis will cease. Now, some problems that can arise whenever fluid does move in this direction with osmosis, because we have a cell that has such a high osmolarity, is that too much water can go inside that cell, and it can cause it to swell and rupture. And the flip side can happen. Let's say that inside of the cell had a low osmolarity, but the outside of the cell had a high osmolarity, had a lot of solutes, and it didn't have a lot of water. Well, too much water can leave that cell and go in the opposite direction to extracellular fluid, and we could dehydrate that cell and shrink it. Now, the neat thing about this osmosis process is that in healthcare, we can actually use this to benefit our patient, because sometimes patients come in with fluid volume deficit or fluid volume overload, and they need certain fluids to help correct that imbalance. And we can manipulate this osmosis process with those fluids based on the solute concentration of these fluids to help either rehydrate that cell or dehydrate that cell, depending on what's going on with that patient. So we just reviewed how certain transport processes move fluid and substances to and from that cell through that cell membrane. Now let's look at some processes that move fluid from the capillaries to the interstitium, also known as the tissue space, by talking about hydrostatic and oncotic pressure. Hydrostatic pressure and oncotic pressure are two pressures that literally work the opposite of each other, but they work beautifully together to help maintain fluid going across our capillary wall into our interstitium, our tissue space. With oncotic pressure, it's going to pull water across that capillary wall, and hydrostatic pressure is going to push water across that capillary wall. So first, let's talk about oncotic pressure. So oncotic pressure, you may hear also referred to as colloidal osmotic pressure. So if you also hear that term as well, that's what it's talking about, because sometimes that can get a little confusing. And this is that pulling force on water created by proteins, specifically the protein albumin, which is known as a colloid. And a cool thing about albumin is that a lot of it hangs out in our blood plasma, and it is way too big to pass through that capillary wall. So it just hangs out there in that blood plasma, in that intravascular space, in high concentrations. And whenever it does this, by hanging out in high concentration, it creates an osmotic pressure, which pulls water through a process known as osmosis. And we just talked about osmosis, and we know that osmosis occurs because water loves to be where there's a high concentration of something, hence solutes. And in this case, we're talking about albumin. So there's a lot of albumin hanging out in this capillary wall, which is going to result in water being pulled in. So water is going to stay inside that capillary, which is what we usually want. So again, just to drive home that point, let's look at this illustration. We have this example of a capillary, and in white, you see all these colloids, hence albumin, the proteins hanging out within this vessel, and it's highly concentrated. So what it's going to do is it's going to pull water from that surrounding area, that interstitial area with the fluid in there, and it's going to cause water to stay inside that vessel. And the reason it's doing that is because there's a high concentration of that albumin inside that vessel. It causes osmotic pressure to occur, which is going to pull water in there, and water is going to stay inside that vessel, hence our capillary. Now, sometimes problems arise in some patients where they don't have enough of this albumin in their blood plasma, and they're experiencing a condition known as hypoalbuminemia. And this can happen in cases of liver or kidney failure because your liver makes albumin, so you just don't have enough in your blood, or the patients, let's say, had severe burn, so we've dropped those levels. So what do you think is going to happen if you don't have enough albumin in your blood plasma? Well, your oncotic pressure is really going to be affected. You're not going to have a lot of it because there's not enough of it hanging out in the blood to create that pressure. So instead, water is going to leave that blood plasma, go into that interstitial space, and we're going to experience swelling. Now let's talk about hydrostatic pressure. So this is the opposite of oncotic pressure because it creates a pushing effect on water across that capillary wall. And in other words, really what hydrostatic pressure is it's the pressure or force of a fluid inside a restricted space. So in our body, when we're trying to think of that, the restricted space is going to be our blood vessels, hence our capillaries, and that fluid is going to be our blood. So what happens is that this pressure is created somewhere, and it's created by our heart. So our heart contractions create hydrostatic pressure, and hydrostatic pressure varies throughout your circulatory system. It's really high in the arteries, and we need it to be high in the arteries because your arteries take that fresh, oxygenated, nutrient-rich blood and needs to push it out throughout your body. So we need hydrostatic pressure to be high. But as we get closer to the venous system, it gets lower because the venous system's job is to take that used blood back to the heart so we can make it better again, give it more nutrients. So whenever you're looking at the capillary and you're trying to figure out where these pressures are highest, on the end of the arterial part of the capillary is where the hydrostatic pressure is the highest versus where it's the lowest, which is the venous end of the capillary. And the whole goal of hydrostatic pressure is that it needs to create a process known as filtration because we need to get this water and solutes out of the capillary into their interstitial fluid so it can go and do its thing and then come back to us. So what hydrostatic pressure does is it's that pressure that pushes that water and solutes out of the capillary into the interstitial fluid, which is again known as filtration. So as you can see with these two processes, oncotic pressure and hydrostatic pressure, how our body needs them to work. We have one that's going to push out the water and the nutrients, which is hydrostatic pressure, and then we have the other oncotic pressure, which is going to pull it and keep it inside the vessels. Now let's take a look at hormones and fluid regulation. The water in our body must be balanced. We can't have too much or too little, and if we do, we start to have major problems. So whenever an imbalance starts to occur, we have hormones and certain systems in our body that will kick in to hopefully help correct those imbalances. So in this lecture, we're going to review those hormones and systems. So I'm going to be talking about the renin-angiotensin-aldosterone system, known as RAS. I'm also going to be talking about the thirst mechanism and review those hormones known as antidiuretic hormone, which is known as ADH, aldosterone, and the natriuretic peptide hormones. So first, let's review the renin-angiotensin-aldosterone system, also known as RAS. Okay, so let's say you have a patient who has fluid volume deficit. So thinking back to our lecture on fluid volume deficit, we know that our patient has low fluid in their body. And this can cause a low blood pressure. And our body doesn't like a low blood pressure. So whenever it senses this RAS system is going to kick in. And the whole goal of this system is to increase your blood pressure. And how it does this is it gets angiotensin II involved, which is a hormone that's also going to stimulate other hormones such as aldosterone and ADH, that antidiuretic hormone. And those hormones are going to add more water to your blood to help increase blood volume, hence increase blood pressure. So how this system works is that your blood pressure drops. That drop in blood pressure indicates to the body, hey, we have a loss of fluid, so we've got to do something about this. And this causes the kidneys to respond, specifically the juxtaglomerular cells inside that kidney. And they are going to release a substance called renin. And whenever renin is present in the blood circulation, this causes the liver to respond. And whenever the liver responds, it is going to activate a substance called angiotensinogen. And whenever angiotensinogen is there, it actually turns into a substance called angiotensin I. So we have angiotensin I, but again, the whole goal is to get angiotensin II involved because that is that big major hormone that's going to actually cause some things to happen. So we've got to get there. Now, how do we get there from angiotensin I to angiotensin II? Well, that is where ACE comes in. ACE stands for angiotensin converting enzyme, and this helps turn angiotensin I into angiotensin II. And now that we have angiotensin II involved, things are going to start getting interesting because now we'll be able to achieve our goal of increasing that blood pressure because angiotensin II has major effects on the body. One thing it does is it causes vasoconstriction. So we're going to get narrowing of those vessels. And when we narrow those vessels, it's actually going to constrict the blood flow to the kidneys and limit its ability to excrete water, which is what we want because we want that water to stay in the body right now so we can increase our blood volume, hence increase our blood pressure. In addition, angiotensin II is going to cause our adrenal cortex to release a hormone called aldosterone. And aldosterone will cause the kidneys to keep sodium, which will also cause us to keep water. And again, we want to do this because we're trying to increase our blood volume. So whenever this happens, your patient will have a temporary decrease in their urination, which again is what we want. And then another thing angiotensin II does is it causes the posterior pituitary gland to release a hormone called ADH, which again is antidiuretic hormone. So how this works is it's going to cause the kidneys to keep water. And whenever we keep water, we're going to increase blood volume. So think of it this way. If you're familiar with how diuretics work, we give patients diuretics to help them urinate extra fluid out of the body. It's used to treat a lot of times fluid volume overload. Well, if we're having a substance in our body called antidiuretic, anti means works against, we're working against that concept. So let that help you remember what ADH does. ADH is going to cause your body to keep water. It has an antidiuretic effect. And then lastly, another thing angiotensin II does is it stimulates the thirst mechanism. So let's review how the thirst mechanism regulates fluid in our body. So whenever this mechanism is stimulated, it's because, again, of low fluid in the body. So whenever you have low fluid in the body, think about your blood plasma's osmolality. How's it going to be? It's going to be high because you're going to have a low amount of fluid in there, but a lot of solutes. So whenever we have a high blood plasma osmolality, it's going to cause the hypothalamus to respond, particularly the osmoreceptors inside the hypothalamus. And look at that word, osmoreceptor. We have osmo, and we're talking about osmolality. So these receptors are very sensitive to how the blood plasma's osmolality is. That's how they respond, is based on if it's high. So whenever they respond, they cause antidiuretic hormone to be released, ADH. Now ADH is also called vasopressin, and ADH is actually made in the hypothalamus, but it's stored and it's secreted in the posterior pituitary gland. And this is when the thirst sensation is going to be experienced. So the person is going to have this desire to drink fluid. So once ADH is secreted, it's going to cause the kidneys to respond. They sense that ADH hanging out. And it's particularly going to cause the nephrons within the kidneys to start doing some things a little bit differently. So your nephrons are all those little structures within the kidney that really work to keep the kidney functioning and help create your urine. So the ADH is going to act on two particular parts of that nephron. It's going to affect the distal convoluted tubule and the collecting duct. It's going to cause those structures of the nephron to actually reabsorb water. So instead of taking water and putting it back into that nephron, hence into the filtrate so it'll be urinated out, instead it's going to cause your body to reabsorb that water and put it back into the bloodstream, which is what we want because we're on a fluid volume deficit and we need water back into the body. So water is going to be retained. And whenever we retain this water, it's going to help our plasma osmolality. So instead of being so high and high of solutes, we're going to add water back to it, help water it down just a little bit and even out the water and the solute concentration so we can normalize the osmolality. So we just reviewed hormones and systems in our body that help us correct a fluid imbalance where we don't have enough fluid in the body, known as fluid volume deficit. But how do we prevent those systems from doing their job too well, where they add way too much fluid into our body and send us into fluid volume overload? Well, we have a group of hormones that help prevent that. They really keep those system and hormones in check, and they're known as the natriuretic peptide hormones. And one of these hormones is known as atrial natriuretic peptide, also known as ANP. And this hormone is secreted by heart cells when there is stretching of that atrial wall. And remember, the atria are the top chambers of the heart. Then we also have what's called BNP, and you may hear BNP a lot whenever you're taking care of a heart failure patient because these patients are in fluid volume overload, and BNP stands for brain natriuretic peptide hormone. And this is a hormone that is actually released by the heart cells whenever there's a lot of ventricle wall stretching. So whenever we had the RAS, aldosterone, ADH, and thirst mechanism doing their thing, they were adding water back into our blood system. So whenever that water is added back in there, it's going to go up and it's got to go into the heart because the heart's job is to pump that extra fluid out throughout the body. Well, when you're adding just too much, your heart's going to start to sense that because it just wants to get it at a right point so it doesn't overstretch. Because if it's overstretching those atria and ventricles because that water, that extra water in the blood is going there, it's signaling, hey, we may be going into fluid volume overload. So these hormones are secreted by those heart cells that make up the atria and the ventricles. And what these hormones are going to do is they're really cool. They actually work against angiotensin 2 because angiotensin 2 was our big star of the RAS system. That's what got aldosterone, ADH, that thirst mechanism, all of that involved. So it's going to stop the effects of aldosterone, ADH, and renin so we don't go into a fluid volume overload. So it's like a check and balance type hormones that help us manage our fluid. Now let's dive a little deeper and look at the lab values you want to know. So what are they? Well, a CBC, a complete blood count. This tells us about the cells in our blood, like our red blood cells, white blood cells, platelets, all those important cells that help us maintain life. In addition, arterial blood gases, ABGs. This tells us the acid-base imbalance in our patients. Especially if our patient's having a respiratory or metabolic problem, it can tell us how bad it is and if our treatment is working to help correct the problem. Another thing is metabolic panels. This can be a basic like a BMP or comprehensive like a CMP. And this tells us really important things like our patient's fluid and electrolyte status. How's our potassium, our sodium, our calcium, glucose, along with our patient's renal function, their BUN and creatinine. And if it's comprehensive, it can tell us how that liver is performing as well. Another thing you want to know, especially if your patient's on anticoagulants, are their coag levels, their coagulation levels, like that PT-INR, APTT. And this is going to tell us how our patient's clotting, what's their clotting time, and if they're therapeutic on their medication. And lipid panels. This is assessing the patient's cardiovascular risk for disease. And we're looking at the LDL, the HDL, the total cholesterol, and triglycerides. And the last thing are those drug levels, because many of our patients are on drugs that have this narrow therapeutic level, like digoxin, dilantin, lithium. And we want to know, is it safe to give this drug? What's their drug level? Now, when you take the NCLEX exam and you're looking at those lab values and you're trying to determine, is this normal or abnormal? You need to know that NCLEX is going to give you something that is noticeably abnormal. It's not going to be right on the line or close to the normal range. And the reason for that is because lab ranges for the normal really vary depending on the lab and the text. Like, for instance, some things will say that a normal mag is 1.5 to 2.3, while another one may say it's 1.5 to 2.5. So NCLEX is going to give you something that's really abnormal, and you're going to know it's abnormal. So first, let's start out talking about the complete blood count, the CBC. This tells us about the cells in our blood. So what's a normal RBC range, a red blood cell range? It should be 4.5 to 5.5 million. For white blood cells, WBCs, it should be 5,000 to 10,000. For platelets, it should be 150,000 to 400,000. Now, some terms you want to be familiar with would be like thrombocytopenia. What is that? That is a low platelet count. So if they say that to you, you know that's going to be less than 150,000. Or how about a patient with leukopenia? That is a low white blood cell count, so a count less than 5,000. Now let's look at our hemoglobin and hematocrit levels. This tells us about our red blood cells, and we really use this when we're transfusing packed red blood cells. We want to know that hemoglobin level really. And it varies between the female and the male, and I would remember the differences. For a female, a normal hemoglobin range is 12 to 16 grams per deciliter. A normal hematocrit is 37 to 47%. And for a male, a normal hemoglobin is 14 to 18 grams per deciliter. And a normal hematocrit is 42 to 52%. Now let's look at coagulation levels. If your patient's on an anticoagulant, you definitely want to know their coagulation levels. For instance, if they're on warfarin, you want to know their PT-INR. And if they're on heparin, you want to know that APTT. So let's look at this PT-INR. PT stands for prothrombin time, and a normal PT level in someone who's not on any anticoagulant should be 10 to 12 seconds. An INR is calculated from the PT, and INR stands for International Normalized Ratio, and normally it should be less than 1, and this is for someone who's not taking any anticoagulants, specifically warfarin. But how about if they are taking warfarin? What do we want that INR level to be so they're therapeutic, so this drug is working to prevent blood clots? We would want their INR to be between 2 to 3. So if it's less than 2, this Coumadin, this warfarin, is not really achieving what we need. So their dose would need to be increased. If it was way greater than 3, they are at risk for bleeding. So their dose would need to be decreased. Now let's look at this APTT. This stands for Activated Partial Thromboplastin Time. And this is used for patients who are taking heparin. A normal APTT in a patient who's not taking heparin is 30 to 40 seconds. Now, if they're taking heparin, we need them to be within this certain range so they're therapeutic and this drug is working. So we would want it to be 1.5 to 2.5 times this normal range, which ends up being about 60 to 80 seconds. Now, if they were less than 60, that would mean that we're not achieving what we need. They're not therapeutic, so their dose would need to be increased of heparin. If they're greater than 80 seconds, it's taking them way too long to clot, so they really have too much heparin in their system, so their dose would need to be decreased. Now let's switch and let's look at the metabolic panel. Again, this is going to tell us about our fluid and electrolytes, which will include glucose, glucose, our renal function, and if it's comprehensive, it's going to tell us how our liver is functioning as well. So let's look at these ranges. Okay, glucose. A normal glucose is 70 to 100 milligrams per deciliter. Calcium level is 8.5 to 10.5 milligrams per liter. Chloride is 95 to 105 milliequivalents per liter. Magnesium is 1.5 to 2.5 milligrams per deciliter. Phosphorus is 2.5 to 4.5 milligrams per deciliter. Potassium is 3.5 to 5 milliequivalents per liter. And a sodium is 135 to 145 milliequivalents per liter. Now, how I remember those is that they're like multiples of 5. Like everything is represented with 5. So if you can remember that, it'll help keep you straight. Now let's look at our renal function. Our BUN and creatinine will tell us that. A normal BUN is 5 to 20. A normal creatinine is 0.6 to 1.2 milligrams per deciliter. Now we're getting into liver function. So let's look at total protein. That is 6.2 to 8.2 grams per deciliter. And then albumin. This is another protein. Remember, albumin played a huge role in regulating our oncotic pressure. And it's 3.4 to 5.4 grams per deciliter. Then we have these 3 enzymes that are found in the liver. It's the ALP, the ALT, and the AST. And if these are abnormal, it could indicate liver disease or some type of other disease in the body. So a normal ALP, which stands for alkaline phosphatase, is 40 to 120 units per liter. Then we have ALT, which stands for alanine transaminase, and a normal range is 7 to 56 units per liter. And then the AST, which is aspartate transaminase, a normal is 10 to 40 units per liter. Then the last part of our metabolic panel is the bilirubin, and this substance is created when you have the breakdown of red blood cells. And when red blood cells break down, they release this reddish orangish color, and a normal bilirubin level should be less than 1 milligrams per deciliter. But if your patient has an elevated one, you will notice that they will have this orangish yellowish hue to their skin or this mucous membrane where all this bilirubin has collected in the blood and has just leaked into the skin, giving them that like pumpkin hue appearance. Now let's look at the lipid panel. This test is going to tell us about our patient's risk for cardiovascular disease, and it's going to look at the LDL, the HDL, the total cholesterol, and the triglycerides. So LDL, this stands for low density lipoprotein, and we want this value to be low. So we want it to be less than 100 milligrams per deciliter. Now the HDL, which stands for high density lipoprotein, we want this number to be high, and we want it greater than 60 milligrams per deciliter. So some people get these confused, but how I remember it is that L for LDL stands for low, so we want that number low, and the HDL, it stands for high, so we want this number high. Now total cholesterol, we want that less than 200 milligrams per deciliter, and then triglycerides less than 150 milligrams per deciliter. Now let's move on to arterial blood gases, ABGs. I have a whole video on how to interpret ABGs to know if it's respiratory metabolic problem, if it's acidosis, alkalosis, compensation, partial compensation, and check out that video because it'll show you how to do the tic-tac-toe method and really simplify how to get those answers. But you want to know the normal ranges for those. So a blood pH is 7.35 to 7.45. Anything less than 7.35 is acidic. Anything greater than 7.45 is alkaline. Then we have a PCO2. The normal range for that is 35 to 45. And I have switched them here because anything greater than 45 is acidic and anything less than 35 is alkaline. Then we have bicarb, HCO3. The normal range is 22 to 26, and anything less than 22 is acidic, and anything greater than 26 is alkaline. Then we have PO2, which normal is 80 to 100%, and then we have the oxygen saturation, and a normal is about 96, 95 to 100%. Now let's switch to the hemoglobin A1C test. This test is really helpful in helping us determine the average glucose in a person over the last 3 months. So it's great for patients who have diabetes so we can see their average glucose. So what do we want this number to be? Well, in a person who does not have diabetes, we would want them to have a hemoglobin A1C of 4 to 6%. But if they have diabetes, we would like for their target hemoglobin A1C to be less than 7%. Now let's wrap up this lecture and let's talk about the most common drug levels you may encounter on NCLEX. So first up is digoxin. A normal dig level is 0.5 to 2 nanograms per milliliter. Then we have carbamazepine, which is Tegretol. Normal level is 4 to 10 micrograms per milliliter. Dilantin, a normal level is 10 to 20 micrograms per milliliter. Then theophylline, normal level, same as Dilantin, is 10 to 20 micrograms per milliliter. Then we have phenobarbital, a normal level is 15 to 40 micrograms per milliliter. Lithium at 0.5 to 1.2 millimoles per liter. And then lastly, valproic acid, also known as Depakote. It is 50 to 100 micrograms per milliliter. Now we're going to review the electrolytes and imbalances that can occur. We need a proper balance of fluid and electrolytes in our body in order to maintain life. We don't need too much or too little. We need a specific range. In fact, 70% of our body is actually made up of water. And here you can see the function of the water in our body. It's found in our brain, in our muscles, bones. It helps transport nutrients and oxygen into the cell. Also, our blood consists of 83% of water. But this just isn't plain water. It consists of many things, and one thing it consists of are electrolytes. So what are electrolytes? Well, we're going to be talking about 6 main ones, such as potassium, sodium, chloride, calcium, phosphate, and magnesium. So these are substances that once they enter the body and they are dissolved in water, hence our blood, they actually produce an electrical charge, hence become ions. And this is very important with electrical signaling in our body. So some things that electrolytes do in our body are the following. They help with contraction of muscles, sending nerve impulses, creating bones, balancing the fluids in our body like our cells via osmosis, and maintaining the blood's acid-base balance. Therefore, whenever we have these imbalances of these electrolytes, you're going to start to see certain abnormalities in these processes, depending on if it's high or low. For example, with contraction of muscle, in certain electrolyte imbalances, you can start to see muscle spasms, or your heart, which is a muscle, will start to demonstrate abnormal EKG findings. And it's very specific to certain electrolytes. And as we go through this lecture, I will highlight that for you. But now let's talk about how electrolytes are maintained in our body. How do we keep them from being too low or too high? Well, we get electrolytes majority from our food whenever we eat and drink. And it goes into our body, and majority of them are going to be absorbed in our gut. So if you have a gut problem, let's say an issue with your small intestine, that can affect how you are absorbing certain electrolytes. Then it enters into our blood, and you know that your blood has to be filtered by your kidneys. And just remember the kidneys. Really, if you have any kidney problems, you're probably going to have an electrolyte problem. And your kidney is made up of all these little functional units called nephrons. And the nephrons, in a sense, what they do is they take your blood and they create filtrate out of it, which in the end is going to be urine. And it's like a little pipe. I like to think of it as it runs through the kidney, and the filtrate is going to go through certain sections of that pipe. We call them tubules, and certain electrolytes and water and other things are going to be taken out of the blood and put in the filtrate, or it's going to stay in the blood and you're going to keep it in your body. So whatever your body doesn't need, as it tweaks these electrolytes, you will urinate out as urine. So think about it this way. If you have any problem with the renal system, you can affect the electrolytes. Hence, a lot of times they're going to be really high. So that's why many times patients who have high abnormal electrolytes will need to go for dialysis, because that dialysis machine is going to replace what that kidney's nephrons should be doing. In addition, we can manipulate the kidneys and by giving them diuretics. So a lot of times if we give too much of a diuretic, we can cause these electrolyte imbalances. So other ways our electrolytes can be affected is that if we have an exit route for them, and this could be anything. It could be trauma. It could be where we've had a lot of blood loss, or we've had burns, or the patient's just really sick. They're throwing up a lot through vomit, or they have diarrhea. Maybe they have suction, NG suction. We're sucking off too much of those gastric juices, which are rich in many of our electrolytes. Or the patient has some type of disease process, and you're going to see that a lot with the causes, like problems with aldosterone or ADH, the antidiuretic hormone, etc. Now let's look at these electrolytes individually. First, I'm going to start with sodium. So sodium is a really important electrolyte that loves to hang out outside of your cell. So there's a higher concentration of sodium in the extracellular part compared to the intracellular part, where there's a lower concentration. Now, sodium plays a huge role in regulating the water inside and outside of our cell, along with muscle contraction and nerve impulses. So if you get an imbalance of this electrolyte, you're going to start to see issues with these processes. A normal sodium level is about 135 to 145 milliequivalents per liter. So anything less than 135 is considered hyponatremia, and anything greater than 145 is considered hypernatremia. And you want to remember, the higher the number or lower the number with these ranges, you're going to start to see more profound signs and symptoms. The worse off the patient is going to be. Whenever it's just a little bit over, a little bit under, it's going to be very mild. So now I want you to see a visualization of how sodium really works in that extracellular area and affects the cell. Here we have hypernatremia conditions. So in the blood, there's a lot of sodium hanging out. And you want to remember that water loves sodium. So wherever there's a higher concentration of sodium, that is going to pull water, and water wants to be there. And think of it like this. If you eat a lot of salty foods, what do you start to crave? Water. So it's almost the same concept. So we have lots of sodium in the blood. The water that's in the cell is going to be pulled outside of the cell, and this is going to cause the cell to shrink up. Now on the flip side, hyponatremia. We don't have a lot of sodium in the blood, in that extracellular part, low amounts. So the water's like, hey, we're lonely. So there's some inside the cell. Remember, there's a lower concentration, but there's some. So that's going to cause the water in the extracellular part to be pulled inside the cell. So what's going to happen? The cell is going to start to swell. Now let's talk about the main causes of hyponatremia. What can cause the sodium level in the blood to drop? Well, not consuming enough sodium can do that, along with giving a patient a medication called a diuretic. Diuretics are typically used when a patient has fluid volume overload. They have too much water in their blood, so we're going to manipulate their kidneys to pull that water off, and they're going to urinate that out. And the diuretic family that does that tends to be the thiazides. So they influence the kidneys to really waste sodium, and they're going to be wasting it in their urine, and it'll drop our blood level. Also, anything that's affecting our GI system, because your gastric juices have a lot of sodium in them, so vomiting or GI suction with an NG tube, that can waste the sodium level along with the potassium level as well. Diarrhea, sweating, which contains a lot of sodium, and Addison's disease. So let's do a quick review about Addison's disease. This is where a patient has low aldosterone. What is aldosterone? Well, it plays a role with our blood pressure, helping us maintain our blood pressure. So normally it will cause the kidneys to keep water and sodium, because that will increase your blood pressure, but in exchange for that you're going to excrete potassium. So if we have a low level of aldosterone, how's that going to affect the water and sodium? It's going to cause you to lose it, so you're going to lose your sodium. But on the flip side, it's going to cause you to keep your potassium. So that can cause that, and also SIADH, which stands for Syndrome of Inappropriate Antidiuretic Hormone Secretion. And this is where they secrete too much ADH, which again is antidiuretic hormone. What does this do? Well, whenever we're diuresing someone, we're causing them to lose lots of fluid through their urinary system. Well, if we that antidiuretic hormone, that's going to cause them to keep water, not urinate it as much. So we're going to have more water in the body, and in turn that's going to dilute the sodium. Some other conditions that can do that as well is whenever we have overload of fluid in the body, like with congestive heart failure, giving the patient too much of a hypotonic solution, or renal failure. Now let's look at the signs and symptoms associated with hyponatremia. So to help you remember those signs and symptoms, remember the word salt loss, because we have a loss of sodium. S is for seizures and stupor. So stupor is where you have a decrease in consciousness, like confusion, and this can be associated with the nerve transmission being affected, along with, depending on how severe it is, those brain cells start to swell. A is for abdominal cramping, L for lethargic, T for tendon reflexes diminish, trouble concentrating, L, loss of urine and appetite, O for orthostatic hypotension, overactive bowel sounds, S for shallow respirations, and this happens late due to skeletal muscle weakness, and then S is for spasm of muscles. Now let's talk about the main causes of hypernatremia. What causes our body to keep too much sodium in our blood? Well, if you have some issues with certain hormones, like in Cushing's syndrome, our body is keeping too much cortisol, so we have an overproduction of this, and this, remember from our other lectures, plays a role with the stress process. So some functions of cortisol would be to help us maintain our blood pressure with the inflammatory process. So if we have too much of this, we're actually going to keep too much sodium in our blood, and we're going to waste too much potassium. So we'll have hypernatremia, but hypokalemia. In addition, Conn's syndrome can cause hypernatremia, and this is also known as primary aldosteronism, and this is where we have too much aldosterone being present in our body. Over here, we had Addison's where we had low aldosterone, so it's going to cause the opposite effect. So with this, remember the normal role of aldosterone was to maintain our blood pressure with the water and sodium and excreting potassium. Well, if we have too much of this on board, we're going to keep too much water and too much sodium, hypernatremia, and we're going to excrete our potassium, and we can drop our levels and get hypokalemia. In addition, hypertonic solutions, giving a patient too much of a salty solution, as I like to think of it, in the blood, and corticosteroids can do this. If a patient is not drinking enough water, that can concentrate the sodium in the blood, or if they're losing too much water. And a condition that can do this is like diabetes insipidus. That can happen as well. The patient is going to be urinating so much with this condition. In addition, burns can cause this, and an increased intake of sodium can cause this condition as well. Now let's look at the signs and symptoms associated with hypernatremia. And to help you remember those, let's remember the phrase, no fried foods for you. And a lot of times fried foods are packed full of sodium, so we know we're dealing with a lot of sodium here. So the F is for fatigue. They'll feel very tired. R is for restless, really agitated. They're going to be confused because you're having central nervous changes. I for increased reflexes. This can progress to seizures and coma. E for extreme thirst. This is a huge sign. Remember this one. And then D is for decreased urinary output and dry skin / dry mouth. Now let's look at the electrolyte chloride. So I want to do chloride after sodium because these two electrolytes really go together. If there is generally a loss of sodium, there's also going to be a loss of chloride, and you're going to see a lot of overlapping causes and signs and symptoms. So chloride is very important for helping maintain our acid-base balance because of its relationship with bicarb. Also, it plays a role in digestion because we need it in order to make hydrochloric acid, and it plays a role with balancing the fluids in our body with the help of sodium. A normal level is 95 to 105 milliequivalents per liter. Now, chloride levels are maintained with the help of our kidneys. They tweak our blood and decide, okay, how much chloride we need. If we don't need a lot, we're going to excrete it. Also, it's excreted through the sweat and the GI juices. So if you have some issue with the kidneys or sweating too much or GI juices, chances are you can imbalance your chloride levels. So let's look at hypochloremia. So this is where we have low blood levels of chloride, and some main causes are typically GI related, where the patient is losing a lot of chloride through vomiting or their gastric juices like suction, or if they have an ileostomy. An ileostomy also can cause hyponatremia because this is where a surgical procedure has been created to bring the small bowel on top of the skin, so the patient is having effluent, which is stool, coming through that. Now this is really rich in sodium, also chloride. So if they have where they're putting out a lot of effluent, that can cause these levels to drop. Also, diuretics can cause it, thiazides, that was very similar to hyponatremia. Burns and cystic fibrosis. With cystic fibrosis, these patients lose a lot of chloride, especially through their sweat. And patients who have fluid volume overload, like heart failure, SIADH, that's going to dilute the chloride. And metabolic alkalosis can do this as well. This is where we have a high level of bicarb, and this is going to drop our chloride level. And the reason it does this is because bicarb and chloride have this like opposite relationship, especially in how they shift in and out of the red blood cell to help with proper gas exchange. Now, the signs and symptoms of hypochloremia don't have their own specific ones compared to these other fluid and electrolytes. They typically are going to be associated with whatever's causing this problem. And if you can really remember the signs and symptoms of hyponatremia, you can remember what hypochloremia is going to be, because they really overlap. So you may see dehydration signs and symptoms with an increased heart rate, along with a decreased blood pressure, fever, vomiting, diarrhea, or being lethargic. Now let's look at hyperchloremia. What can drive that chloride level up? Well, it's going to be similar to the causes of hypernatremia, because again, sodium and chloride really go hand in hand. So consuming too much sodium can drive the chloride level up, like giving the patient too many hypotonic solutions. Also, the patient not drinking enough or losing too much water can dehydrate them, raising that sodium level up. Along with the chloride, decreased bicarb level. Whenever the bicarb drops, that can increase the chloride because of their opposite relationship. So losing too much with maybe having too much diarrhea. Also, the Conn syndrome, this is where they have the increased aldosterone, so the patient is going to be retaining a lot of sodium but excreting potassium, and that can elevate our chloride level. Medications like corticosteroids, and then metabolic acidosis can do this as well. Maybe a medication leading to this condition or some type of renal problem. Now, the signs and symptoms of hyperchloremia are similar to hypernatremia and acidosis. Now let's look at the electrolyte potassium. So potassium has an opposite relationship with sodium compared to how chloride had the similar one. So chances are, if you have a high sodium level, you're going to have a low potassium level. If you have a high potassium level, you're going to have a low sodium level. And this is because, potassium is mainly found inside our cell. There's a higher concentration there. Sodium, the higher concentration was on the outside of the cell. So they work together to help balance that fluid within the cell, plus they play a huge role together with the sodium-potassium pumps. Now, the role of potassium is big with muscle contraction and nerve impulse. So if you have an imbalance of this electrolyte, you're going to start seeing issues with this. A normal potassium is about 3.5 to 5 milliequivalents per liter. So as you can see, it's a very narrow range, but it's a very important electrolyte. So let's look at whenever we have hypokalemia. So we have low potassium in the blood. What are some main causes of this? Loop diuretics can cause this, like furosemide. It causes your kidneys to waste potassium, so that's a big thing you got to watch on those patients. Corticosteroids can do this, and if a patient has too much insulin. The reason for this is because insulin makes potassium move inside the cell. So if we're causing it to leave the blood and go inside the cell, we're dropping our blood levels. Cushing syndrome can cause this. This was the high cortisol. So again, it decreases the potassium, increases the sodium, and we talked reason for that earlier. Starvation, patients who have been under extreme conditions where they haven't been able to eat can cause this. Or losing too much potassium, and this is again found richly in those GI juices. They're like vomiting or GI suctioning through the NG tube. Now, what are the signs and symptoms that you may see in a patient who has hypokalemia? So we have a low potassium level in our blood. Remember that everything is going to be low, but it's also going to be slow. So remember the 7 L's. L represents low. So the first L is that the patient is going to be very lethargic and they can be confused. Second L is for low, shallow respirations. Third L is lethal cardiac dysrhythmias. They may have ST depression, a shallow T wave, or a projecting U wave. Fourth L is lots of urine. They can have frequent urination where the kidneys are just unable to concentrate the urine. Fifth L is leg cramps. Sixth L is limp muscles, and they may have decreased deep tendon reflexes. And then our last L is for low blood pressure and heart rate. Now, what can cause hyperkalemia, where we have too much potassium in our blood? Well, anything that really causes the potassium in the cell to move outside of the cell into the blood is going to raise those blood levels. So if a patient has severe burns, this can occur along with tissue damage, such as the condition like rhabdomyolysis. This is where you have the breakdown of muscle tissue. So whenever that muscle tissue is breaking down, it's leaking potassium into the blood, hence increasing it. Addison's disease can do this, and again, this is where we have decreased aldosterone. So we're going to be excreting our sodium, but keeping our potassium. Renal failure, a lot of times whenever you have patients who have an elevated BUN and creatinine, you are going to definitely see that potassium level increase very high. A lot of times they need dialysis to bring it down. Medications can do this as well, like those potassium-sparing diuretics, like spironolactone, and ACE inhibitors can do this, and NSAIDs. Now, what are the signs and symptoms of hyperkalemia? Well, to help us remember those signs and symptoms, let's remember the word murder, because if the potassium level gets too high, in the end, it's going to murder the patient. So M is for muscle weakness. U is for urinary output is going to be little or none. This is very common in patients who have renal failure. They're putting out like no urine. R is for respiratory failure. Whenever it gets so high, those muscles are going to just quit working and they're not going to be able to breathe. D is for decreased cardiac contractility. They're going to have a weak pulse, low heart rate. E for early on, you're probably going to see muscle twitches and cramping. And then R is for rhythm changes, and I would remember this. They are going to have tall, peaked T waves. You can also sometimes see prolonged PR interval. Now let's talk about the electrolyte calcium. This is an essential ion that plays a huge role in the health of our bones and our teeth, along with muscle and nerve conduction and clotting. So in order to maintain a good level of calcium, we have to have a diet that's rich in calcium. So our gut plays a huge role with us absorbing calcium, and once we absorb it, what we really don't need to maintain that good blood level is going to be stored in our bones. Now our bones will monitor our blood levels, and if those levels are low, like in hypocalcemia, what will happen is that the bones will actually start to release calcium into the blood. But if this keeps happening over and over, it's going to make this bone really weak over time, and the person can have osteoporosis, break their bones. Now, calcium is really regulated by 3 different things. 1, vitamin D. It's very important a person has vitamin D on board in order to absorb calcium. Also, the parathyroid hormone, PTH, and calcitonin play a role with this. PTH is produced by the parathyroid gland, and calcitonin is produced by the thyroid gland. So, if you have destruction to these glands, or maybe a patient's had surgery, we can alter calcium levels if we hurt these glands. Now, a normal calcium level is 8.5 to 10.5 milligrams per deciliter. So let's talk about what happens whenever we get a really low level of calcium. We start to experience hypocalcemia. So what can cause this is a decrease in the parathyroid hormone, and typically this is going to happen with patients who've had surgery of this structure, especially like a thyroidectomy. So if you've had a patient who's had thyroid surgery, check their calcium level because we could have damaged that gland. A decreased intake of calcium, for some people this is very hard to keep their calcium levels maintained, especially if they have lactose intolerance. So they'll have to be very conscious about making sure they get enough calcium through other sources. Having a low vitamin D level can cause this as well, because vitamin D plays a role with us absorbing calcium. Chronic kidney disease, because the kidneys are wasting too much calcium. Bisphosphonates can cause this as well. This is a medication that's actually used to help treat osteoporosis, so to make those bones stronger. And how it does this is it helps decrease the release of calcium, but sometimes we need the release of calcium into the blood, and if we don't get that, we can have low levels. Also, another group of medications include the aminoglycosides. These are antibiotics. They end in mycin, M-Y-C-I-N. They cause the body to waste calcium via the kidneys, and then some anticonvulsants like phenobarbital, and this affects the vitamin D levels in the body. Now, what are the signs and symptoms of hypocalcemia? Well, we know that our muscles and our nerves are definitely going to be affected. So let's remember the word cramps. C is for convulsions. R is for reflexes, hyperactive. When you check those deep tendon, they will be like that. A is for arrhythmias. They will have a prolonged QT interval if it's severely low enough. M for muscle spasms in calves or feet. This is known as tetany. Then P is for positive signs, and these are signs that you can see in a patient who has a really low calcium level. So one of these signs that you definitely want to remember is called Trousseau sign, and this is where you can take a blood pressure cuff, put it on the arm, inflate it to a number greater than their systolic, and leave it there for 3 minutes. Now, if it's positive, you will notice the hand will draw in toward the body, and flexion will occur at the wrist, thumb, and MCP joints, but the fingers will remain extended. Then another sign that you want to remember is called Chvostek sign. And this is nerve hyperexcitability of the facial nerve, specifically that cranial nerve 7. And to elicit this response, you're going to tap via the masseter muscle at the jaw's angle, and the facial muscles on that same side that you tapped will contract momentarily. So the lips will twitch. And then S is for sensation of tingling and numbness, known as paresthesia, and this can be felt in the fingers and toes. Now, what can cause hypercalcemia, increasing the blood level of calcium? Well, if you have an overactive parathyroid where you're having too much parathyroid hormone in the body, because parathyroid hormone is going to cause the release of calcium. If we have too much, we're going to release way too much calcium in the blood. Next is increased vitamin D usage, because vitamin D helps us increase our calcium, helps us absorb it. So we have too much, that can increase it. Or using supplements with too much calcium in it. If a patient has cancer that has spread to the bones, this can affect calcium levels because it causes too much calcium to leak into the blood. And then medications, some main ones you can remember are like the thiazide diuretics can do this because it affects how the kidneys are absorbing calcium. And then lithium can do this as well, because lithium can affect the parathyroid hormone, causing the body to have too much calcium. Now, what are the signs and symptoms that a patient has too much calcium in their blood? Well, this patient is going to be extremely weak. So W is for weakness of the muscles. It'll be very profound. E is for EKG changes, and remember they can have a shortened QT interval. A is for absent reflexes. They can also have altered mental status and abdominal distension from constipation. And then K is for kidney stone formation. So these patients are at risk for the development of kidney stones. Now let's talk about the electrolyte magnesium. So this electrolyte likes to hang out inside the cell, just like potassium did. And it has a function in nerve and muscle, which plays a role with the sodium and potassium pump. So with this pump, you have ATP. And what happens whenever magnesium binds with ATP, because ATP needs it in order to function, it's going to move 3 sodium ions out of the cell and 2 potassium ions into the cell. Therefore, we need a proper balance of magnesium in order for this function to occur. In addition, it plays a role with our vessels, maintaining our blood pressure and how our muscles contract and relax. So with magnesium, what happens with contraction? You have calcium. That's the big one that plays a role with that. But in a nutshell, magnesium competes with calcium for that binding spot. So whenever relaxation is going to happen, we have magnesium that allows that to happen. So think about this. If we didn't have enough magnesium, if it allows us to have our muscles relax, what's going to happen instead? Instead, your muscles are going to have spasms, they're going to cramp and have contraction issues. So magnesium is mainly absorbed in our gut, specifically our small intestines. So if we have issues with our gut, as you're going to see with our causes, we can have issues with balancing our magnesium levels. And magnesium imbalances will more than likely present with other electrolyte imbalances like that of calcium and potassium. So a lot of times if your calcium levels are low, your magnesium levels will be low and vice versa. Now a normal magnesium level is 1.5 to 2.5 milligrams per deciliter. And if you can see that range, it's very narrow. So let's talk about low levels of magnesium in the blood. This is known as hypomagnesemia. And what can cause this is not consuming enough magnesium, or we have some other electrolyte imbalances, like we have issues with calcium or potassium, or we have malabsorption disorders of that small intestine that can cause that. Or they are taking a PPI, a proton pump inhibitor, that can decrease the absorption of magnesium. And patients who have alcoholism can have this as well. Now let's talk about the signs and symptoms of a low magnesium level. So with this, you want to remember the word twitch, because everything in the patient is really going to be excited. It's going to be hyperactive. On the flip side, whenever you have a high mag level, everything is going to be really slow and not hyperactive. So T is for Trousseau sign and Chvostek sign, and this is related to also having a low calcium level, so hypocalcemia. W is for weakness. I is for increased deep tendon reflexes. Again, everything's going to be hyperactive. T is for Torsades de Plant, and this is an abnormal heart rhythm that can lead to sudden cardiac death, and it can be a lot of times seen in patients who have alcoholism. And then another T for this part is tetany, those seizures, and other EKG changes that go with the calcium and the potassium being decreased. C is for calcium and potassium levels low, they'll present together. And then lastly is H for hypertension, because magnesium helps with our blood pressure, and having a low amount can make those vessels more likely to lead to hypertension. Now let's look at the main causes of what can elevate the magnesium level in the blood, known as hypermagnesemia. Well, this condition is relatively rare. It tends to happen whenever we're trying to correct a low magnesium level, so we give them too much. Or you want to monitor a patient for this condition if they're an OB patient, labor and delivery. The patient has preeclampsia and they're receiving magnesium sulfate, so we want to monitor their mag levels to make sure we're not giving them too much. And you're checking those deep tendon reflexes, making sure they're there, because if they're not there, we may have a problem with our magnesium level. Also, renal function can mess this level up as well, causing us to keep too much magnesium. Now with this condition, with the signs and symptoms, everything in your body is going to be lethargic. It's not going to be really hyperactive like over here. So let's remember the word lethargic. And typically with this condition, you're only going to see it in severe cases. Mild cases may not present with signs and symptoms. So L is for lethargic and may be profound. E is for EKG changes with prolonged PR and QT intervals and maybe a wide QRS complex. T is for tendon reflexes absent or grossly diminished. H is for hypotension. A is for arrhythmias like bradycardia, heart blocks. R is for red and hot face. They're going to have flushing. GI issues is for G, nausea and vomiting. I is for impaired breathing due to skeletal muscle weakness. And C is for confusion. They can have neurological impairment. Now let's talk about our last electrolyte, phosphate. So phosphate plays a role in teeth and bone building. It's stored in the bones. It's absorbed by the gut and excreted in the kidney. So any issues with those structures, we're going to have an imbalance of phosphate. It's also regulated by the parathyroid gland, because the parathyroid gland will tell the kidneys to inhibit reabsorption. And then vitamin D influences how we absorb phosphate. So are you seeing the parallels between calcium and phosphate? They have some similarities. So a normal phosphate level is anywhere between 2.5 to 4.5 milligrams per deciliter. So let's talk about if we have a low phosphate level in the blood. This is known as hypophosphatemia. What can cause this? Overusage of aluminum-based antacids. Too much of this will block the gut's absorption of phosphate, lowering our level. Also, starvation and refeeding syndrome can cause this. Refeeding syndrome occurs when a patient has experienced severe starvation. They haven't had any food, and then whenever we give them food, it can increase their blood sugar because that's what it normally does. But because they've went under such extreme conditions in their body, when this insulin is released because of this high blood sugar, it's going to need phosphate to change glucose into energy. So that is going to further deplete those phosphate levels, leading to the low blood levels of phosphate. Also, an overactive parathyroid can do this, because if we have too much parathyroid activity, we're going to majorly inhibit how the kidneys are reabsorbing phosphate. Hence, we're really wasting it all and not getting it in our system. And then low vitamin D levels can cause this as well, because vitamin D plays a huge role in absorbing phosphate. Now let's look at the signs and symptoms of hypophosphatemia. And to help you remember the signs and symptoms, let's remember the word bone, because phosphate is huge with our bone health. So B is for bone pain and fractures. O is for osteomalacia, and this is where you have softening of the bones. And whenever you have this, especially in children, it can affect their growth, making them shorter, and it can result in the bowing of the legs, how the bones are formed. N is for neurostatus changes. They can have irritability, confusion, seizures. And then E is for erythrocyte destruction. So phosphates play a huge role with our red blood cells. So we can have our red blood cells being destroyed, and this can lead to hemolytic anemia. Now let's look at elevated phosphate levels in the blood, also known as hyperphosphatemia. So overusage of phosphate-containing laxatives like Fleet's enema can cause a high phosphate levels. So if a patient has renal failure, you definitely want to watch using those. Too much vitamin D on board can cause it as well. Rhabdomyolysis can cause this. I mentioned this earlier. This is where the muscles start to become damaged. When they break down, that contents of the muscle is going to go to the kidneys, because your kidneys filter your blood, and it's going to damage your kidneys. And when your kidneys get damaged, we're not going to be able to deal with phosphate like we should, and we'll keep too much and have high levels. And then hypoparathyroidism, so an underactive parathyroid. What's going to happen, instead of normally being able to inhibit reabsorption of phosphate by the kidneys, we're not going to have that. Instead, we're going to keep more, so that will elevate the levels. Now, the signs and symptoms of hyperphosphatemia can be similar to that in hypocalcemia. So patients with high phosphate levels may be experiencing convulsions. They may have hyperactive reflexes, arrhythmias, spasms in their muscles. They may also have itching. This is found in a lot of renal patients, and they can have signs of Trousseau's and Chvostek's. Now let's talk about the IV fluid types. IV fluids, also known as intravenous fluids, are special fluids that we administer to the intravascular space, which is part of the extracellular compartment space. And administering IV fluids is a very common treatment that patients get whenever they come to the hospital. And as a nurse, our role revolves around administering these fluids to this space. And we do that per the healthcare provider's orders. And these fluids can be used to treat a wide variety of conditions, really anything that's affecting these compartment spaces where we need to replenish that fluid. Let's say the patient's dehydrated, they may need some fluids to help them with that. Or they're having electrolyte imbalance or an acid-base imbalance. We can use these fluids to help correct that. Therefore, as a nurse, you want to be familiar with the different types of IV fluids, such as isotonic, hypotonic, and hypertonic. You also want to know how they work once we administer them to the body, and what you need to monitor for while your patient's receiving these fluids. But before we go over these different types of fluids, I first want to go back and review the different body fluid compartments. Now, the average adult body is made up of about 60 to 70% of water. So that is a lot of fluid within our body. And this fluid has to be stored somewhere. And there are two main compartments that stores this fluid that I want you to remember. The first compartment is known as the intracellular compartment. And this is the fluid that's found within the cell. And intra means within. So remember, this is the fluid inside of our cell, as you can see here. Then we have the extracellular compartment, and this is the fluid found outside of that cell. And extra means beyond or outside, so we're talking about that fluid that is surrounding the cell. And it is made up of the intravascular fluid, which you can see here. This is also referred to as the plasma. Then we have the interstitial fluid, which you can see here in blue, and it's just hanging out around our cells. And then we have the transcellular fluid. So now let's take a closer look at these body fluid compartments, with the first being the intracellular space. So again, this was the fluid found inside of the cell, and this space actually accounts for 2/3 of our body body water. So most of our fluid is inside of our cells. And then there's the extracellular space, which again is that fluid outside of the cell. And it accounts for 1/3 of our body water, and it includes the fluid compartments such as the interstitial fluid compartment. And the interstitial fluid compartment is the fluid that surrounds the outside of our cells. And this fluid plays a very vital role in helping be a medium for electrolytes and other substances to move to and from the cell to the plasma with the assistance of the capillaries. And the intravascular fluid compartment, which again is known as the plasma, is the fluid found inside the blood vessels, which contain so many important substances like electrolytes, blood cells, and so forth. And then lastly, we have the transcellular fluid compartment. And this is actually the smallest compartment, and this is the fluid that is found within certain body cavities, like the spinal fluid, the fluid that surrounds our heart and lungs and the joints. Now, it's important to note that these compartments are really all interconnected with their own amount of water and electrolytes, and they will work together to help maintain a homeostatic environment in our body. And how they do this is that they will shift water, electrolytes, and other nutrients around so we can keep that balanced environment. And they do this shifting through various processes in the body, with one of those processes being osmosis. Therefore, in healthcare, we can administer IV fluids, let's say, to this intravascular compartment to help expand it if we need to, or shift fluids around these compartments via this process of osmosis to help us correct fluid imbalances or other problems that can occur within the intracellular and extracellular spaces. So to help us understand how IV fluids do this, let's talk about osmosis. So osmosis is a process where water is going to move from a fluid of a higher water concentration to a fluid of a lower concentration. In other words, water is going to move from a fluid that has a low solute concentration to a fluid that has a higher solute concentration. And it does this passively. It doesn't need any energy or anything from the cell. It actually does this on its own, and it does it through a semi-permeable membrane, which is only permeable to water molecules. So let's illustrate this process by looking at this drawing. Here we have our semi-permeable membrane, which is only permeable to water. And on one side of the membrane, we have a lot of water molecules, but we don't have a lot of solutes. And on the other side of the membrane, we have not a lot of water molecules, but a lot of solutes. So according to osmosis, what's going to happen is that water is going to move from a higher concentration of water to a lower concentration of water. Or you can look at it this way. Water is going to move from the place where there's not a lot of solutes to a place that there are a lot of solutes. Now, the big takeaway I want you to get from osmosis is that this process is highly influenced by a fluid solute concentration. And depending on how concentrated that fluid is of the solutes will determine how osmosis is going to affect how water is going to shift from this extracellular space to the intracellular space, or vice versa. So what is a solute? A solute is a solid that has been dissolved in a liquid. And there's many different substances out there that can become a solute in a liquid solution, with one being like sodium and chloride. So we can take sodium and chloride in their solid form, put them in a liquid. Whenever we do that, once they dissolve, they become an electrolyte. But there's still a solute in that fluid that we have. Now we can take that and we can administer it to the patient in their intravascular system. Now, depending on how much sodium and chloride we actually put in that fluid will determine how the process of osmosis is going to be affected in this extracellular and intracellular compartment. So that leads me to osmolarity. What is osmolarity? Osmolarity is the amount of solutes within a specific fluid volume. So in other words, it's the total solute concentration per liter of solution. So depending on that IV fluid's osmolarity will depend on how well osmosis is going to work within the body to shift fluid around these compartments. So we can term fluids as having a high osmolarity or a low osmolarity. So whenever a fluid has a high osmolarity, we're saying it has a lot of solutes in that fluid. Whenever something has a lot of solutes in it, it has less water. On the flip side, if a fluid has a low osmolarity, it has a low amount of solutes in it, meaning it's going to have more water in it. And in healthcare, we can use osmolarity to our benefit to help treat patients who are sick and need fluids replaced based on what compartment we need to treat and shift fluids around. We do this by administering various types of fluids that have different osmolarities or solute concentrations, which will move water in or out of these compartments. Now let's talk about the different types of IV fluids and their tonicity. So again, there are three main types of IV fluids. They are isotonic, hypotonic, and hypertonic. And let the prefix and the suffix of these fluid names help you determine what type of fluid we're dealing with. So the prefix iso means equal, and this means the fluid solute concentration matches or is equal to that of the blood plasma. Hypo means low, and this means that the fluid solute concentration is lower than the blood plasma. Whereas hyper means high, and this means that that fluid solute concentration is higher than the blood plasma. And then when we look at the suffix tonic, this is for tonicity, and it tells us about the fluid's ability that will be entering that extracellular space, hence that intravascular space, how well it's going to move water in and out of that intracellular space, hence inside the cell, or not at all. Will it keep it equal, or is it going to build up both parts? And this is based on the concentration of electrolytes, hence those solutes, in the IV fluid. So first is isotonic IV solutions. These have the same osmolarity as the blood, so same concentration of solutes. And with these fluids, there's going to be an equal transfer of water, so our cell is going to stay the same. Therefore, we can just use these fluids to expand extracellular fluid volume, hence our plasma. Now, why would we want to expand the extracellular fluid? Well, if the patient is experiencing a fluid loss in this space, like through vomiting, diarrhea, they need some sodium and chloride back, or they're experiencing hypovolemic shock, burns, or maybe they're going to be having surgery, and we know with surgery, they're going to be losing a lot of blood, like that extracellular fluid. Now, some fluids that are considered isotonic are normal saline, lactated Ringer's solution, also called LR, and 5% dextrose in water. Now, there's an asterisk by this, and I'll tell you about this fluid here in a second, because although it is isotonic, it does work as a hypotonic solution once administered. And some things you want to remember about isotonic solutions is that with normal saline, this replaces just water, sodium, and chloride, and it is the only solution we use to administer with blood. So you don't use any other solution, only normal saline. And with this type of solution, you have to watch out for fluid overload, especially in patients with kidney and heart failure, because their heart and kidneys aren't working too great, and if we put too much fluid in there, they can become overwhelmed, and we can actually put too much fluid back into the extracellular space. Therefore, you want to monitor their blood pressure, make sure they're not hypertensive. You also want to check their breathing and check those lung sounds. Make sure that you don't hear any crackles, which could indicate pulmonary edema, where we've had fluid build up in the lungs. And then also look at their extremities, especially those lower extremities. Make sure there's no edema present. And because we are administering sodium and chloride, you want to also check those sodium and chloride levels. Make sure that they're not increasing, because this fluid could cause that if we give too much. The next is 5% dextrose in water, D5W. This solution replaces water and glucose. So as I pointed out earlier, it starts out as isotonic but ends up as a hypotonic solution. And why is this? Well, in this solution is dextrose, and when dextrose enters the body, it will be used up by the body, hence metabolized. But what's left over is not very concentrated. It's really just free water. So we have a low osmolarity and it becomes hypotonic. Therefore, because of the components of this fluid, it's not for fluid resuscitation situation. It can actually increase the blood glucose too high, causing hyperglycemia. But it can help hypernatremia. That is where we have too much sodium in the blood. And what this fluid will do, because it's hypotonic in the end, it can help in a sense water down that blood, hence decreasing our sodium level there. And then lastly, with LR, this solution contains water, potassium, potassium, sodium, chloride, calcium, and lactate. Now this fluid contains lactate, and lactate can actually help increase the blood's pH by converting to bicarbonate, which is really helpful whenever we have acidotic conditions going on, like mild cases of metabolic acidosis. However, it's not for patients with liver disease because our liver converts lactate to bicarbonate, or for patients who are experiencing lactic acidosis because already in the body there's a high amount of lactic acid. So we don't want to go and add more. And because this fluid contains potassium, you would want to monitor for hyperkalemia, high potassium level in the blood, especially if your patient has some type of renal insufficiency. Next are hypertonic IV solutions, and these solutions have a higher osmolarity than the blood, so they have a higher concentration of solutes in the fluid. Now because of this, osmosis will cause water to leave the intracellular space, hence it could shrink the cell, which can help expand the extracellular space. Now why would this be beneficial? Well, if we have a patient who has a severely low level of sodium, so they're having severe hyponatremia where they don't have a lot of sodium in that blood, or they have brain swelling, which is cerebral edema. Now some solutions that are considered hypertonic include 3% saline, dextrose 10% in water, dextrose 5% in normal saline, and then dextrose 5% in half normal saline. Now some things you want to remember about these fluids whenever you're administering them is that you want to use them very cautiously because they have the risk of overloading that extracellular space because we're pulling fluid from inside the cell, because remember, a lot of fluid hangs out inside that cell to that extracellular space, which in the end could overload our system, leading to pulmonary edema. In addition, because these solutions are highly concentrated of, let's say, like saline, they could cause hypernatremia, so we'd want to check sodium levels of the blood. And when you go to administer these solutions, you always want to check with your facility's protocol on how to properly administer hypertonic solutions, because some may recommend that all hypertonic solutions have to be administered through a central line rather than a peripheral IV, while others may say just 10% or higher concentrations have to be administered through a central line. And the reason for this is because if hypertonic solutions get in the surrounding tissue, it can be very damaging to those cells and tissue. So we have to watch out for extravasation. And then lastly, hypotonic IV solutions. So these solutions have a lower osmolarity than the blood, hence a lower concentration of solutes in the fluid. And because of this, osmosis will cause water to move from the extracellular space to the intracellular space, which can swell the cell to the point where it may rupture. Now these fluids are going to help dilute the extracellular space and replenish the inside of the cell. And why would this be beneficial? Well, if there's too much solute concentration in the blood, for example, the patient has hypernatremia, we can dilute that with these solutions. Plus, it can help provide free water to help the kidneys excrete waste and prevent dehydration. And some hypotonic solutions include half normal saline, 0.225% saline, 0.33% saline, and of course the 5% dextrose in water. But again, that started out as isotonic, but once in the body, it becomes hypotonic. So it goes between both. And some things you want to remember as a nurse about hypotonic solutions is that they cause the cell to swell because fluid is leaving the extracellular fluid and going into the intracellular fluid, which could cause brain swelling. So you want to monitor for mental status changes, low blood pressure, hypovolemia. And because we are giving some free water to the extracellular space, we could give too much. So that could really water down the sodium level. So you want to monitor for hyponatremia and then monitor patients who are more fluid sensitive, especially if they have heart failure and renal failure, because they cannot handle the extra water. So now let's look at the differences between crystalloids and colloids. Both of these solutions are administered IV, so to that intravascular space. And both of these solutions expand our plasma volume. Now, whenever I say expand plasma volume, what I'm talking about is that we are adding more fluid to into that intravascular space. So we're adding more fluid into our blood vessels. So first, let's take a look at colloid solutions. These solutions can include natural and synthetic type solutions. For instance, a natural type of colloid is known as albumin, whereas we can have synthetic types, which includes dextran, hydroxyethyl starches, and gelatin. And how these fluids work is that they are going to pull water into that intravascular space. Now, how do they do this? Well, whenever you're administering a bag of colloids, inside that bag, you have very, very large molecules. So whenever those molecules go inside the intravascular system, they are unable to actually escape that capillary wall because they're just so big. So because they can't escape that capillary wall, high concentrations of them hang out inside the intravascular system. So whenever we have a high concentration of something hanging out in there, what's going to happen is that that's going to increase oncotic pressure. Another term for oncotic pressure is known as colloid or colloidal osmotic pressure. And this results in water being pulled from around that blood vessel, so from that interstitial fluid. So water is going to be pulled inside that blood vessel, hence our intravascular space, and it's going to expand the volume, hence the fluid inside that vessel. And this is something we definitely want whenever our patient is experiencing hypovolemic shock, severe burns, or they've had some type of severe bleeding. And because how these fluids work, they are fast at expanding this plasma volume because they have such a great effect at pulling that water across that capillary wall into the intravascular space. So the amount administered, so the amount of colloids we give the patient is usually equal to the amount of fluids that the patient has lost. So we don't have to just throw in a bunch of colloids to this patient. Now, there are some downsides to these fluids. Two things, big things, is that they can have allergic reactions and coagulation problems with these solutions. So we really have to monitor for that as the nurse. Plus, they're not as easily accessible and they tend to cost more. Now let's compare this to crystalloid solutions. So crystalloids, they include hypertonic, hypotonic, and isotonic solutions. So in these bags of fluid, we have fluid, but we also have electrolytes, and they are smaller molecules, whereas with colloids, those are big molecules, typically like proteins. But these are electrolytes. Therefore, because they're smaller, they don't hang out as long in that intravascular space. And because of this, the patient is going to need high amounts of these fluids in order to replace the amount of fluid they have lost. So they really carry a huge risk with fluid volume overload. And these fluids can work in a variety of ways depending on the tonicity of the bag of fluid. For instance, whenever we're dealing with hypertonic crystalloid solutions, we have a high tonicity, so there's a high amount of solutes in that bag of fluid compared to the tonicity or the osmolarity of your blood plasma. So when we throw a hypertonic solution into that intravascular space, what it can do is that it can pull water from the cells and dehydrate them, which sometimes we need to do that if we have like cell swelling like with cerebral edema. However, on the flip side, hypotonic solutions work in an opposite way. They, in this bag of fluid, they have a lot of fluid, but they don't have a lot of solutes. So it has a lower osmolarity, hence tonicity, than compared to your blood. So whenever you throw those fluids into that intravascular space, it can cause water to go inside of the cell, which sometimes is what we need when that cell is dehydrated. But sometimes it can cause problems because it can cause that cell to swell and rupture. And then we have isotonic fluids, and iso just means equal. So that bag of fluid, its tonicity has the equal amount of solutes compared to your blood. So it's the same type of tonicity. So whenever we put that isotonic solution into the blood, it doesn't really cause this mass movement of fluid in and out of the cell. It really is just going to expand that intravascular space. And all of this is happening because of osmosis. Now, some good things about crystalloid solutions that unfortunately colloid solutions did not have is that crystalloid solutions do not cause allergic reactions or coagulation problems. Plus, they are easily accessible. You can typically go in your clean hold and get whatever type of fluid you want based on what the doctor ordered. And they tend to cost less, which is really good for the patient. Next up is hypervolemia. Fluid volume excess is sometimes referred to as fluid volume overload, overhydration, hypervolemia, or water intoxication. So it has a lot of names. And what's happening is that there is just too much fluid in our body, and our body needs just the right amount of fluid in it in order to be able to function. If it has too much or too little, it's going to start to fail, and you're going to start to see these certain signs and symptoms. So with fluid volume overload, where is all this fluid hanging out? Well, whenever the system becomes overloaded, this fluid likes to go into the different fluid compartments we have in our body. So let's quickly review those fluid compartments. So the first fluid compartment we have is called the intracellular compartment, and this is the fluid found inside of the cell. And there's actually a lot of fluid inside the cell. It accounts for 2/3 of our body water. Then we have the extracellular compartment, and this is the fluid outside of the cell and accounts for about 1/3 of our body water. And we can take that extracellular compartment and divide it into other sections. For instance, part of the extracellular compartment is the interstitial compartment, and this is the fluid that is found around those cells, so outside of the cells, in between them. Then we have the intravascular compartment, and this is our blood plasma. As nurses, we access this compartment a lot. Whenever we're starting IVs, we are getting access to this compartment. And many times the reason we're even accessing this intravascular compartment is because we need to give them fluids. And then there's another part of the extracellular compartment known as the transcellular. And this is the smallest part of all the extracellular compartments, and it's the fluid that is found around certain joints and certain organs in our body, like the heart and the lungs. And all of these compartments are really interconnected. They work together because they can shift fluid around as needed to help correct certain problems. And they do this through various processes, with one process being osmosis. And osmosis is highly influenced by the osmolarity, hence the solute concentration of a fluid. And what happens in osmosis is that water is going to move from a fluid that has a low osmolarity, hence a low concentration of solutes, to a fluid that has a higher concentration of solutes, hence a higher osmolarity. So depending on where those solutes are hanging out will depend on where that fluid is going to move. And these are all important concepts that you want to be familiar with to help you understand the different types or causes of fluid volume overload. So there are 3 types of fluid volume overload. We have hypertonic, hypotonic, and isotonic. So first, let's talk about hypertonic fluid volume overload. With this type of overload, there's going to be the movement of water from the intracellular compartment to the extracellular compartment. And this happens due to an increase of osmolarity, hence the solute concentration in the extracellular compartment, which cause fluid, hence our water, to move from that intracellular compartment to the extracellular compartment. So we're going to have an increased amount of water here in this extracellular compartment. Now, when you're trying to think of the causes of this type of overload, think of causes where we're introducing something in the body that has a high concentration of solutes, hence a high osmolarity. And this would happen if the patient ingested too much sodium, because remember, water loves sodium, and whenever we have a lot of sodium on board in the body, water just flows to it, and whenever it flows to it, we're going to increase our fluid volume. In addition, excessive administration of hypertonic IV solutions can do this as well, because what's happening is that we're administering these high osmolarity fluids, hence they have a high solute concentration to that intravascular space, which is part of the extracellular compartment, and it's going to cause water to be pulled from the intracellular space, the inside of the cell. It's going to shrink it down, but that fluid's got to go somewhere, and it's going to go into the extracellular space, and we're going to overload that compartment. Then another type of overload is called hypotonic fluid volume overload, and this is also sometimes referred to as water intoxication. Therefore, we're increasing body water but not osmolarity. We're actually going to dilute the solutes, and with this we're going to have the movement of water from the extracellular space to the intracellular space. So you're going to have an intracellular compartment that's going to become overloaded along with the extracellular compartment, so both compartments. And when you're trying to think of the causes of this, think of causes where free water is just being introduced introduced into the body. One way is through excessive intake of free water orally. And a condition that can cause this is known as primary polydipsia. And this is where the patient has a very strong compulsion to just drink water over and over. So as they introduce all this water into their system, they become water intoxicated. And it will water down the extracellular compartment, hence changing its osmolarity, which is going to, according to osmosis, pull water into the intracellular compartment, which will overload it as well. SIADH can also cause this as well, and this stands for Syndrome of Inappropriate Antidiuretic Hormone. And this is where there's too much antidiuretic hormone being released. And antidiuretic hormone is also referred to as ADH. And whenever we have too much ADH on board, what happens is that we are retaining way too much water in our body, and we're going to have this same concept happen. We're going to have fluid volume overload. We're going to dilute everything really, especially sodium, in that extracellular compartment. And then lastly, we have isotonic fluid volume overload. And this is sometimes referred to as hypervolemia. This is a very common type of overload that we see in patients. And with this, there is no movement of water between those compartments like how we had with the other two, because osmolarity is equal. Remember, iso means equal. So we're not going to have the shifting of this fluid, but we're going to have the overload of the extracellular compartment, because we can have problems with major organs in our body that normally help us regulate our fluid volume. For instance, if we have heart failure or kidney failure, it can lead to this type of overload. Or if we administer too much isotonic IV solutions to the patient, we can overload the cellular compartment. In addition, overusage of corticosteroids can lead to this, because corticosteroids cause our body to retain sodium and water. Now let's talk about the signs and symptoms of fluid volume overload. So to help you truly understand what you're going to be seeing in your patient, you need to think about what is going on with my patient. Well, we've already established that the patient is overloaded with fluid in their body fluid compartments, and they are just oversaturated with fluid from head to toe. So signs and symptoms are going to be based on how they're affecting that certain body system. So first, let's start with our head, the neuro part. So from a neuro standpoint, you want to monitor for brain swelling, because what happens is that those cells that make up your brain can start to expand and swell, and this can lead to mental status changes, and that is actually one of the earliest signs and symptoms that your patient is experiencing brain swelling. So be monitoring for confusion. In addition, what can happen is that your patient can experience a headache or pressure in the head from that fluid overload. Now let's move down to the cardiovascular system. So this system has a lot of fluid in it, and it can become overwhelmed quite easily. And how I like to think of this system being affected is the same concept with a water hose. So your water hose is like your vessels in your body, and if we have a lot of water connected to that water hose, there's going to be a lot of pressure in it. And almost the same is true for your body. If you have a lot of fluid in that system, you're going to have a very strong bounding pulse whenever you go to feel the patient's pulses, because we have a lot of fluid in there. They are going to have a high blood pressure, so hypertension. In addition, their jugular veins are going to be distended, so they can have JVD, which is known as jugular venous distension, and they can experience sinus tachycardia. Then we can move out from this system to the respiratory system, and our lungs can be majorly affected, especially depending on how severe the fluid volume overload is, because then fluid can start to leak into our lungs and cause pulmonary edema. So you may see that the patient has shortness of breath with any simple activity. They're having difficulty breathing. You could also hear crackles in their lungs whenever you listen to them. And here's an example of what crackles may sound like. In addition, the respiratory rate can be increased, and they can have this dry, hacking cough. Now, this cough can actually become productive, and if it becomes productive, this is a really bad sign. Whenever they start to cough, it will be this like foamy, frothy, blood-tinged sputum. That tells you that you need to get your patient treatment immediately because they're experiencing like flash pulmonary edema. And then we start to see signs and symptoms peripherally, where we're going to see swelling and edema in the upper and lower extremities. And this edema can actually pit whenever you touch it, which we're going to go over here in a moment in nursing interventions. The skin will also feel cool to the touch because it can be so swollen that will diminish blood return, causing it to feel cool. And the abdomen can be swollen, which we term ascites, because fluid can back up into our liver veins, which can cause congestion. In addition, the patient can have nausea, where there's just so much pressure in the belly, and the patient is going to have weight gain. And one thing you want to remember about weight gain that's helpful, especially whenever you're monitoring the patient, seeing how much fluid they're losing, is that 1 kilogram, which is 2.2 pounds, is equal to about 1 liter of fluid. So whenever we're diuresing them, we definitely want to monitor their weight. But whenever they're having fluid volume overload, weight gain is one of those signs and symptoms they can experience. Now let's talk about labs and diagnostics. What are you going to see as a nurse whenever your patient has fluid volume overload? So remember, your patient has a lot of fluid in their body. So if we have a lot of fluid and other fluids of the body, what is it going to do to the concentration of electrolytes or other important things in that blood? It's going to dilute it. So it's going to decrease it. When we go and get our reports back, we're going to see that certain labs are going to be decreased. And the reason they're decreased is because we have way too much fluid watering down that blood and that urine. So remember, everything is going to be diluted, which starts with a D, and everything is going to be decreased. So when we look at the patient's hemoglobin and hematocrit, it will be decreased. When we check the patient's sodium level, it will be decreased. It can be less than 135 milliequivalents per liter. In addition, their BUN, along with a decreased serum osmolality, and this is the concentration of substances in the blood. So because we have so much fluid in there, it's going to be diluted. And when we check the urine, there's going to be a decreased urine-specific gravity and osmolality test. And these look and measure the solute concentration in the urine. The urine-specific gravity actually looks at the number and size of them, and the osmolality looks at the number of them, the electrolytes. So again, it's diluted and it's going to be low. Now, if the patient has a really severe case of fluid volume overload, we can look at a chest x-ray and we could see pulmonary edema where there's fluid in those lungs. Now let's talk about nursing interventions. So treatment goals revolve around removing this extra fluid from the patient, but we don't want to remove too much fluid from the patient, because if we do, we're going to flip them into fluid volume deficit, and we don't want them to go there. Plus, we don't want to remove too many electrolytes, because we're going to be giving them diuretics and other things which could throw off our electrolyte balance. So as a nurse, we're going to play a vital role in helping administer treatments that removes this fluid, but we also got to monitor those body systems. How are they responding to us removing all this fluid? And make sure that their electrolytes are staying balanced. So what we're going to do is we're going to drain the water. So remember the word drain to help you remember all those nursing interventions for this patient. D is for diuretics. So diuretics are medications we can administer to the patient, and what happens is it causes them to urinate a lot. And what they're going to do is they're going to urinate this extra fluid out. And there's a wide variety of diuretics that can be used. You can use loop diuretics, osmotics, or thiazides. It really depends on the type of overload the patient is experiencing, their renal function, and the severity. R is for restrict fluids and sodium. So we don't want to be giving this patient all these fluids because it's literally going to counteract what we're trying to do for the patient. So they're going to be on some type of fluid restriction. It can be anywhere between 1 to 2 liters of fluid per day that they're restricted to. If your patient does have this, a lot of patients struggle with this. You just want to remind them while we're doing it, and then help them develop a plan of how they can space out their fluid throughout the day if they can cognitively do this with you. In addition, you want to restrict the sodium foods that they're consuming. So chances are they're going to be on a low sodium diet. And again, patients don't like this a lot of times because the food tastes bland. But you want to explain to them why we're on this type of diet. Because sodium loves water. Sodium and water go together, and if we're just throwing in a bunch of sodium, we're going to be pulling a lot of water, and we're not really solving our problem of fluid volume overload. A is for assess daily weights, and assessing a patient's weight is actually a great way to monitor their fluid status. So again, remember, as you're weighing this patient, you need to be doing it at the same time every day with the same scale so we can get the most accurate results. And we want to see how those weights are trending. We don't want our patient gaining more than 2 to 3 pounds in a 24-hour period, because that tells us what we're doing is not working. They're actually gaining fluid. And again, you just want to remember that concept. 1 kilogram, which is equal to 2.2 pounds, equals 1 liter of fluid. So if your patient's losing 1 kilogram, hey, you've removed around 1 liter of fluid. And you also want to routinely be checking their edema. Is it decreasing? So many of these patients are going to have pitting edema, and you want to grade it. And it's helpful to use the lower leg and press over the fibula or tibia region. And here is a little guide to help you grade it. 1+ is like 2 millimeters of pitting. 2+ would be 4 millimeters of pitting. 3+ is 6 millimeters of pitting. And then 4+, which is pretty significant, is about 8 millimeters of pitting. And if your patient is very edematous in these extremities, you want to know that that skin is very fragile and that can easily break down. So you want to reposition these extremities and keep them dry and clean. I is for intake and output, strict measurements. So you want to know everything that patient is taking in, not only orally, but through their IV, flushes, anything you give that patient, and exactly what they're putting out. This is a very important measurement because one reason is you're giving them diuretics, and you want to make sure that they're putting out enough urine, because if they're not, we may be over diuresing them and they're starting to get kidney problems. And then we want to make sure that the patient's just not taking in too much fluid, so it's really counteracting what we're doing. And then lastly is N for sodium level monitored along with other electrolytes, because we can again throw these patients into electrolyte imbalances. Our sodium could be naturally diluted because of the fluid volume overload, and we want to make sure it doesn't get too severe where they're going into hyponatremia. Plus, we're going to be giving them diuretics, for instance, like loop diuretics, and these like to waste potassium. So we want to make sure that they're not experiencing hypokalemia. Now let's look at hypovolemia. Fluid volume deficit occurs in the body because there's not enough fluid in it to support its needs and functions. Now you may also hear fluid volume deficit referred to as hypovolemia or dehydration. And dehydration can occur for many different reasons, with one reason being that there's a loss of water or electrolytes in the body. And we're specifically talking about the electrolyte sodium. Another reason it can happen is because the patient just isn't consuming enough water or electrolytes, or the patient has had something happen in their body where water has shifted around within those fluid compartments. For instance, water has moved from the intravascular compartment to the interstitial compartment, which is referred to as third spacing. So fluid volume deficit results in a deficit of fluid within our fluid compartments. And some fluid compartments can be more affected than others. And this really depends on the type of dehydration that we're talking about. So let's quickly review those fluid compartments. So we have two fluid compartments. We have intracellular and extracellular. Intracellular is the inside of the cell. Extracellular is the outside of the cell. And it can be subdivided into 3 other compartments. We have the interstitial compartment, which is the fluid that surrounds the cell, found in between the cell. Then we have the intravascular compartment, and this is the fluid inside of our vessels. We also refer to this as the plasma. And then we have the transcellular compartment. And this is the smallest compartment of them all. And this is the fluid that is found within certain organs and joints, like your heart and your lungs, etc. And fluid within these compartments can actually be shifted around through a process known as osmosis. And this process is highly affected by the osmolarity of specifically that extracellular fluid. So let's quickly review the different types of movements we can have based on osmolarity. So if we have a hypertonic environment in that extracellular fluid, so we have a high amount of solute concentration, what that's going to do is it's going to pull fluid from the inside of that cell to the outside of the cell, where the cell is going to shrink and become really dehydrated. Then we can have a hypotonic environment where the extracellular fluid is really diluted, so it has a low osmolarity, a low amount of solutes in it. And what's going to happen is that water is going to move from that extracellular compartment to the intracellular compartment inside that cell and cause that cell to get really big and swell, and eventually it could rupture. Then we can have an isotonic environment, and this is where there's an equal amount of solutes on the inside of the cell and the outside of the cell, so we have equal osmolarity. So there's no drastic shifting of water from intracellular to extracellular or extracellular to intercellular. It really just stays the same. So with all those concepts in your mind, let's now take a closer look at the causes of fluid volume deficit and the different types of dehydration. So the first type of dehydration is known as hypertonic. And this is where there's mainly a loss of water rather than electrolytes, hence our solutes, which we're mainly talking about sodium. This is also sometimes referred to as hypernatremia, which means we have a high amount of sodium in the blood. So when we're talking about hypertonic dehydration, we're talking about things causing the extracellular compartment, hence really our intravascular system, to become extremely concentrated with solutes, specifically sodium, and we're going to have less fluid in there. And that's what really hypertonic means. It means that our extracellular fluid has a high osmolarity and again is really highly concentrated of these solutes. So the result of this in these conditions is that water is going to move from the intracellular compartment to the extracellular compartment, and our cell is going to shrink and become dehydrated. So when we're thinking of causes of this type of dehydration, let's think of causes that makes our blood more concentrated, which would be like losing a lot of water. And this is happening in cases of severe diarrhea or vomiting, or with diabetes insipidus. And this is where the patient is passing a high volume of urine due to a low ADH level, which is antidiuretic hormone. And when the patient has this, it's literally just ridding their body of all of this fluid through the urine. So we're not going to have a lot left in our blood, hence we'll have a lot more solutes or sodium. And then another cause is that the patient is just not taking in enough water. And this can happen for many reasons. Maybe they don't have access to water, or they're experiencing impaired thirst, where they're not able to really recognize that they need to take in water, so they easily become dehydrated. And treatment for this type of dehydration is usually to rehydrate that cell. And we can do that by administering hypotonic fluids, because hypotonic fluids change the tonicity or the osmolarity of our extracellular fluid by adding more free water to it, which is hence going to, in a sense, water down that high solute concentration, and it's going to allow osmosis to pull water into that dehydrated cell and rehydrate it. Then we have hypotonic dehydration, and this occurs when there's mainly a loss of electrolytes, hence our sodium, rather than water. So it's the opposite of hypertonic dehydration. And this is sometimes referred to as hyponatremia, so a low sodium level in the blood. And hypotonic means that extracellular fluid has a low osmolarity. So there's this low concentration of solutes, particularly again sodium, in that fluid. And because of these conditions in this fluid, it's going to result in water moving from the extracellular compartment to the intracellular compartment. And the cell is going to swell and possibly rupture. And the problem with this type of dehydration is that it can quickly deplete the intravascular compartment, our plasma, which can result in a low cardiac output. And when you're trying to think of the causes of this type of dehydration, think of causes that lead the body to lose electrolytes or conditions that dilute solutes. And some things that can do this is administering too much of certain diuretics, specifically like thiazides, because thiazides waste too much sodium, or too much free water replacement, because this lowers the amount of solutes, like, with hypotonic solutions. So we have a loss of solute concentration. And starvation or malnourishment can do this because the person is not consuming enough electrolytes. And treatment for this type of dehydration could include administering hypertonic solutions, because these solutions will go in there and help remove the fluid from those swollen cells, because what it will do is it will change the osmolarity of the extracellular fluid, which is going to, through osmosis, draw water out of that swollen cell and put it back into the extracellular compartment. And then lastly, we have isotonic dehydration, and this is where we've had an equal loss of water and electrolytes. And remember, iso means equal. And with this, there's no drastic shifting of water between those fluid compartments. And this is actually the most common type of dehydration we see. And the big problems that arise from this type of dehydration is that intravascular loss can happen, and we're going to lose the ability to pump fluid throughout the body. And this could quickly lead to hypovolemic shock. Causes for this type of dehydration include overusage of diuretics, third spacing of fluids where water shifts from that intravascular space to the interstitial space. The patient has experienced some type of trauma, like they're bleeding out, losing all that fresh, nice blood in the body, or they're experiencing vomiting, diarrhea, or excessive sweating. Now let's talk about the signs and symptoms you're going to see in a patient who has fluid volume deficit. So we know the patient is going to be dehydrated. So D is for dry mucous membranes. When you look at their mucous membranes, they're going to be sticky and very dry and uncomfortable to the patient if they can communicate that to you. E is for early sign. With this, an early sign of dehydration is that they have an increased heart rate. And when you go to feel that pulse, it can feel very weak. H is for hypotension, so a low blood pressure. And the reason they're having this is because they don't have a lot of fluid, blood volume to pump throughout that system. So when we go to measure that blood pressure, it's going to be low. And this can present as orthostatic hypotension. And this is a form of hypotension that occurs when the patient goes from a supine or sitting position to a standing position. And this can happen up to 3 to 5 minutes after that person changes the position. So to have this, the patient's systolic blood pressure, that top number, is going to decrease at least 20 millimeters of mercury, or their diastolic blood pressure number, that bottom number, is going to decrease at least 10 millimeters of mercury. And these decreases are from their baseline blood pressure. So as a nurse, you want to make sure that you get a baseline and you measure these blood pressures at these different positions. Y is for young babies. Whenever they're dehydrated, how you can tell, especially in severe cases, is that they're going to have sunken fontanelles. And these are like those soft spots on the young infant's head that they have because it helps facilitate vaginal birth delivery, because those skull plates haven't fully fused together. So normally they should not be sunken in, and if they are sunken in, this is an extremely bad sign. Then D is for decreased skin turgor. And what skin turgor is it's talking about skin elasticity. So whenever we go to check their skin turgor, instead of just bouncing back real quickly, it can tint, it can be very sluggish, it'll be decreased, that's how we would refer to it. Now, there's a certain patient population you can't really use this as a great indicator of dehydration, and that's the older adults, the geriatric population. Because as we get older, so does our skin elasticity. It's naturally going to decrease in itself. So we want to check other signs and symptoms in those patients. And then we have R, for refill to the capillaries is going to be sluggish. So in severe cases of dehydration, when we go to check that capillary refill, it's going to be sluggish. It can be greater than 3 seconds. Also, attitude changes can occur where the patient becomes extremely restless, lethargic, confused, and it could progress to seizures. So if you start to see mental status changes in a patient with dehydration, this indicates you're dealing with a very severe case of dehydration, because now it's affecting our neurostatus, which we really don't want it to get to that point. And then another sign is thirst. So the patient could just be extremely thirsty. That's trying to replace those fluids that they have lost or those electrolytes. Now, not all patients are going to have this. For example, geriatric patients. As we get older, so does our thirst response. So we're not as responsive to that sensation of thirst. Also, young patients may not even be able to communicate thirst to you, so you definitely don't want to use that as a specific sign for those patients. Experience weight loss is another sign and symptom, and actually measuring a patient's weight is a good way to tell us about their fluid status. So we definitely want to make sure we're weighing our patients. So you want to remember that 1 kilogram, about 2.2 pounds, is equal to about 1 liter of fluid, give or take. So as you're weighing your patient, look at the trending of those weights. If they're experiencing dehydration, are they losing weight? Have they lost 1 kilogram, that could mean that they've lost 1 liter of fluid. And then we have lastly D for diagnostics. So let's go over the diagnostic results that you would be seeing in a patient with dehydration. And the lab results you're going to see really depend on the type of dehydration that the patient has. So you want to keep that in mind whenever we're going over these lab results. But in a nutshell, with fluid volume deficit, what's happening is that we have a low amount of fluid. So when we remove that fluid out of the body, what we have left are those solutes. So the concentration of them are going to be really high in our blood and in our urine. So it's going to be increased all around, which is the opposite of what we've seen in fluid volume overload. Everything was diluted, so everything was decreased because we had so much water watering down those solutes. Therefore, you're going to see an increased serum osmolality, which is measuring the osmolality in the blood. You're going to see an increased hemoglobin, hematocrit, increased BUN, increased sodium level. And again, if we were dealing with hypotonic dehydration, that wouldn't be the case because remember, we're actually going to be lowering our sodium level in that type. So just keep that in mind. And an increased specific urine gravity and osmolality. But again, this is not going to be the case with, let's say, patients who have diabetes insipidus, because that urine is going to be extremely diluted because they are passing high volumes of it from that low level of ADH. Now let's talk about nursing interventions for fluid volume deficit. So the goal is that we want to replace that water and electrolytes that have been lost. And treatment's going to revolve around finding the cause and treating the cause. So let's say the patient is bleeding out somewhere. Well, we want to find why they're bleeding, stop that bleeding, and transfuse them some blood. Or let's say the patient has just been taking too many diuretics, they have urinated all their fluid out. What we want to do is stop those diuretics and infuse some more fluid with electrolytes added to it to help correct that imbalance. So as a nurse, what we can do to help with this whole treatment of correcting fluid volume deficit is that we can provide daily weights. So we want to weigh the patient at the same time every day with the same scale. And we're looking at those weights. Are they trending up? Are they trending down? Now, with fluid volume deficit, we want to make sure that our patient isn't losing weight because that's one of those signs and symptoms. So we're going to be looking at that weight, making sure it's going up. We also want to make sure that we are strictly measuring their intake and output. So everything that they're taking in, this includes IV fluids, IV flushes, anything that they take in orally, or their tube feedings, irrigations, and so forth. And we want to make sure we know exactly what they are putting out. Of course, this is urine, but it also includes vomit, any types of watery diarrhea or suction. We want all that in our calculation. And we particularly want to pay attention to that urinary output because this tells us how well our kidneys are working and if we are improving their hydration status. So we want to calculate that out over that 24-hour period. So you want to make sure that your patient's putting out at least 30 mLs per hour or 0.5 mLs per kilogram per hour, which is based on their weight. In addition, we want to make sure that we are encouraging treatments that help hydrate the body. So for instance, oral hydration, that's one of the easiest ways to help rehydrate your patient. Now, not all patients can do this, and in some cases, they're so severely dehydrated that they're going to need that extra help with those IV fluids. But we want to make sure that our patient has access to these fluids and that they're consuming healthy fluids to promote healthy hydration, avoiding like teas and coffees. And we're going to play a role with administering IV fluids per the doctor's orders. So typically isotonic fluids are used, but in different types of dehydration, for example, hypotonic dehydration, we may want to administer hypertonic fluids. And then in hypertonic dehydration, hypotonic fluids may be used. So it really depends on the type of dehydration your patient has on what fluids we're going to use. And then also we want to make sure that we're looking at those electrolyte reports and checking the sodiums, the potassiums, and all those levels to make sure that they're within normal range. Now let's look at hypovolemic shock. Hypovolemic shock occurs when there is low fluid volume in the blood, hence where the name hypovolemic comes from. Hypo means low, vol means volume, and emic means blood. So we have low blood volume. And we're specifically talking about the blood volume in the intravascular space. And this space contains the volume of blood in a person's circulatory system. So if we deplete that volume of blood in a person's circulatory system, what does that leave that heart to pump throughout the body? Not very much. So what will happen, the amount of blood that this heart pumps per minute is going to decrease. And we're talking about cardiac output. So if we decrease cardiac output, the amount of blood that is going to the cells, tissues, and organs is going to dramatically decrease too. So those cells are going to be deprived of oxygen. And when we do that, cells start to die. And then we start seeing signs and symptoms of shock. Now, a person needs to lose about 15% or more of their volume for signs and symptoms of shock to occur. Now, in the average human adult, they have about 5 liters of blood. So if a person loses 1 liter of that 5 liters, they've lost 20% of their volume. So whenever they lose that much, they're going to start showing signs and symptoms of shock. Now let's talk about the causes of hypovolemic shock. So what can lead to a loss of fluid in the intravascular system? Well, any conditions that really cause fluid to leave the body externally, like there's some type of major injury, so that person is just outwardly bleeding, or there is some type of inside shift of fluid leaving that intravascular space. So let's talk about the 2 types of hypovolemic shock. First type is called relative hypovolemic shock. And this is where you have an inside fluid shift from that intravascular system. And this tends to be a little bit more concealed than the absolute type, which we're going to talk about next. You're not going to see just bright red blood leaving the body like how you could in absolute, and you know that that patient's losing fluid. This can be a little bit more concealed. So this is where fluids or blood is collecting or leaking inside the body. And this can occur with internal bleeding or where you have third spacing of fluid, like with severe burns. And this occurs due to increased capillary permeability. And we talked in depth about this in our burns video. In addition, long bone fractures, they're very vascular, can cause a lot of fluid loss. In addition, damage to organs like in acute pancreatitis. You can see this when a patient develops colon or Turner sign. And colon sign is where you have severe bruising around the belly button, and Turner sign is where you have severe bruising on the flanks. And that can indicate that the patient is having internal hemorrhage, and that occurs with acute pancreatitis. And another thing is like massive vasodilation that occurs in sepsis. The next type is absolute hypovolemic shock, and this is where you have an outside fluid shift from the intravascular system, and this is more noticeable compared to the relative type. And this is where fluid is leaving the body externally. You can see it. And this can occur with massive bleeding that's been experienced due to blood loss with surgery or some type of injury, excessive fluid loss, and this can be through the oral route with vomiting, or the GU route, urination or GI, diarrhea, or sweating with your skin. And many times whenever that occurs, it's being caused by some type of disease process. The patient's really sick, so they're just throwing up a lot, or some type of endocrine disorder. Now let's talk about the pathophysiology of hypovolemic shock and tie in the signs and symptoms associated with this condition. Okay, let's say we have a patient who's in hypovolemic shock, and it's due to like either a relative or an absolute cause, but regardless, what's happened is that their intravascular system, their circulatory system, has been depleted of fluid volume. So what's going to happen is that you're going to get a decreased amount of fluid volume that is returning to this heart to be pumped. So we have a low venous return to the heart. That intravascular system has been depleted of it, so there's really nothing to drain back. Now, whenever that happens, it's going to affect cardiac preload. Now, what is preload? This is the amount that these ventricles stretch at the end of diastole, at the end of that filling phase of the heart. So it's the end diastolic volume. Well, if we don't have a lot of fluid volume draining back to that heart, those ventricles really aren't going to stretch. They don't have to stretch because the fluid volume just isn't there. Now, cardiac preload is a determining factor in stroke volume. And stroke volume is the amount of blood that this ventricle pumps with each beat, which should be anywhere between 50 to 100 mLs. Well, when our stroke volume falls, it decreases cardiac output, because remember, cardiac output is heart rate times stroke volume. And cardiac output is the amount that this heart pumps per minute. And it should be anywhere between 8 to 4 liters. But if we have a decrease in stroke volume, that's going to decrease our cardiac output. Now, when we get a decreased cardiac output, this is going to decrease the amount of blood that's flowing to our organs and our tissues, specifically to those cells. So we're going to get decreased tissue perfusion. And what's that magical substance in the blood that cells love? Oxygen. So when you decrease the amount of oxygen that is flowing to these cells, they're going to start struggling. They attempt to try to save themselves at first by switching the way they metabolize from aerobic to anaerobic. But the problem with that is that you're going to get the buildup of lactic acid, which is going to throw off our pH of our blood, entering into acidotic conditions. And then the body's going to try to compensate, and it's going to activate the sympathetic nervous system and the angiotensin, the renin system. It's going to be shunting blood, all in an attempt to help save the body, save those organs. Now, the signs and symptoms of hypovolemic shock are affected by the percentage of fluid volume loss that patient has experienced. So hypovolemic shock can be divided into 4 classes or 4 stages. And to help you remember those stages / classes, remember the criteria numbers for each percentage loss. So the numbers you want to remember are 15, that's class 1, 15 to 30, that's class 2, 30 to 40, that's class 3, and then the last stage is 40%. Okay, so class 1. This is where the patient has lost less than 15% of their fluid volume, and that's about up to 750 mLs in an adult. Now, during this class / stage, the body can deal with this. It can compensate enough to maintain cardiac output. Now, because of that, your patient's really going to be asymptomatic with a fluid volume loss of less than this. Because remember, at the beginning of the lecture, I said that patients who have 15% or more are going to start showing those signs and symptoms of hypovolemic shock, because the body really can't compensate for that, and it has to turn on its sympathetic nervous system and all of that. So in this class / stage, how do you expect our heart rate to be? It's going to be less than 100. They're not going to have tachycardia. So it's going to be within normal limits, maybe a little bit on the high end, maybe 80s or 90s. Blood pressure, it's going to be within normal limits. Our body is maintaining our cardiac output. Respirations, within normal limits. We're not having any issues with decreased oxygen just yet, because our body can deal with this blood loss. Mental status, they're probably going to be normal. They may be a little anxious, but nothing major. Their skin is going to be warm to the touch. Their capillary refill is going to be less than 2 seconds whenever we check that. And their urinary output is going to be greater than 30 cc's an hour. So kidneys are doing great. That's where we want them. Next, we have class 2, and this is where we've lost 15 to 30% of fluid volume. So anywhere between 750 to 1500 mLs in an adult. So with this, because we've lost more fluid volume than compared to here, our cardiac output is decreased. The body cannot maintain its own cardiac output with this amount of fluid volume loss, so it has to activate that sympathetic nervous system. The body's receptors and the body sense, hey, we can't do this, so those baroreceptors activate it. And that's in turn going to activate our renin angiotensin system. You're going to get shunting of blood away from non-vital organs. So in a nutshell, what you're going to have is vasoconstriction from those catecholamines, from angiotensin 2. And this is going to constrict vessels, and this is going to increase venous return to the heart, which is going to increase our cardiac preload, stroke volume, cardiac output, and increase our blood pressure. So we're going to be maintaining tissue perfusion, making our cells happy, giving them oxygen. Also, we're going to be increasing blood volume through some hormones under the influence of angiotensin II. So we're going to have ADH, the antidiuretic hormone, on board. That's going to cause us to retain water, and aldosterone, which is going to help us conserve sodium and water, and all that in hope of increasing blood volume in the blood, which is going to increase the venous return to the heart, preload, stroke volume, and cardiac output. So our signs and symptoms are going to really be around what's going on, because our body here is compensating with its built-in system. So how do we expect our heart rate to be? It's going to be increased because of the effects of the catecholamines on the heart. So we're going to have some tachycardia going on. It'll be mild. It's going to be less than 120, so less than 120. Our blood pressure is going to be decreased from where that patient normally is, but they're not going to be hypotensive just yet because this system's working to maintain our cardiac output, but it'll be slightly decreased. Our respiratory rate is going to be increased a little bit, just mildly, from everything that's going on. We've dropped in our oxygen, so the body's increasing respiratory to take in some more oxygen to help increase that level. Urinary output, well, what's going on with our ADH and aldosterone? It's causing us to keep water. So our urinary output is going to decrease. So instead of being the normal where we want it 30 mLs per hour, it's probably going to be between 20 to 30. So it's going to decrease. Skin. Now we're diverting blood away from non-vital organs. The skin is one of them. So instead of our skin being warm and flush, it's going to be cool and clammy from where blood is being diverted. Capillary refill, the same concept there. Instead of being less than 2 seconds, it's going to be increased, so greater than 2 seconds. Peripheral pulses, because we're shifting blood away from those extremities, they're going to start becoming diminished and how we feel them. And mental status, instead of just being normal or maybe just a little bit anxious, they're going to start to have some mild anxiety going on. Next is class 3, and this is where the patient has lost 30 to 40% of their fluid volume. And this is anywhere between 1,500 to 2,000 mLs of fluid. Now, because it is this much, the body can no longer compensate. So compensatory mechanisms are going to fail. They're not going to be able to do it. And our cardiac output is just really, it has failed because they've lost so much blood in that circulatory system that the heart doesn't really have much to pump out and maintain perfusion. So you're going to see those cells that make up those organs and tissues, you're going to see malfunctioning of our body system. So we're ending up having failure. So our heart rate is going to be significantly high. It's going to be greater than 120. We're going to have tachycardia. Their blood pressure, they're going to have severe hypotension because we don't have the body being able to maintain blood pressure. So we're going to have some hypotension going on. Respiratory rate is going to be majorly increased. They're hitting respiratory failure territory, so they need mechanical ventilation, intubation possibly to help assist them. Urinary output is going to be low, alluria, so it's definitely going to be less than 30 cc's an hour. We're getting in the renal failure territory where BUN, creatinine is going to be increased. You're going to start seeing buildup of waste in the blood. Liver is going to be failing to help rid us of those toxins. In addition, perfusion to the brain, because our blood pressure is just so low, mean arterial pressure is going to drop, and so brain isn't going to be able to be perfused. So you're going to start seeing some major mental status changes. Here you're going to see confusion, agitation, until it progresses to the next stage where they'll be actually lifeless and a coma. Their skin is going to be cool, clammy, but even take it a step further, it can be mottled. And their pulses are going to be absolutely poor, their peripheral pulses. And the last stage we have is class 4. And this is where the patient has lost 40% or more of their fluid volume, so greater than 2,000 mLs. And this is where death is near. We need to get this patient some very, very fast treatment, dynamic treatment if possible to help prevent that. And what you're going to see with this is just all these vital signs that we're talking about, they're going to be significantly abnormal. So you're going to have major tachycardia, greater than like 140, severe hypotension, major respiratory failure. They're going to be anuric. They're not going to be producing any urine. There's like hardly any fluid to even produce fluid for urine off of. Mental status, like I said, they're going to be lifeless and in a coma. So in a nutshell, whenever you're looking for signs and symptoms, like for your exams for hypovolemic shock, you need to be looking at that heart rate. How's it going to be? It's going to be high. It's going to be tachycardic. How's their blood pressure going to be? Hypotensive. Respiratory rate is going to be increased. Their urinary output is going to be decreased. Their skin perfusion, it's going to be cool, clammy. Capillary refill is going to be down. Mental status is going to be confused. So be keeping all that in mind. And whenever a patient, whenever they have like hemodynamic monitoring, whenever they start getting in these classes of hypovolemic shock, they're going to have that hemodynamic monitoring. So whenever we're looking at central venous pressures, how do you think that number is going to be? It's going to be low. This is where you measure the pressure over here in this right atrium. We don't have any fluid, hardly even in the heart. So the pressure there is going to be low. And if you looked at a pulmonary capillary wedge pressure over here, which looks at the filling pressure in the left atrium, it's going to be low as well because we're depleted of our fluid volume. So remember those two numbers. And it's different whenever we talked about cardiogenic shock. Remember, I talked about the CVP being high, that central venous pressure, and that pulmonary capillary wedge pressure being high. Because cardiogenic shock, we don't have a loss of fluid volume. Our heart's just weak, and that fluid volume, the pressure of it is actually increasing. We're going to have fluid volume overload. So those numbers would be high in cardiogenic shock. Now let's talk about nursing interventions for hypovolemic shock. Okay, what are some treatment goals first? Because that really dictates where we're going with our nursing interventions. One thing, of course, is replacing fluid to this intravascular system. If we can increase the venous return to the heart, we can increase preload, stroke volume, and increase cardiac output, and we get better tissue perfusion. So fluids ordered by the physician are really going to help this patient. And as a nurse, we will be giving those fluids and monitoring them. And it can vary. It depends on what class or stage of hypovolemic shock that patient is in. And you can use various fluids like crystalloids, colloids, blood products. And we'll be talking about all those here in a moment. And of course, correcting the underlying cause of the reason why that patient is losing so much fluid from the intravascular system. So if they're having a massive bleed somewhere, they need to have surgery, repair that to stop the bleeding. So nursing wise, we're looking at a lot of things. We're looking at circulation, perfusion, oxygenation, and we're going to put our nursing interventions and goals for that patient around that. So oxygenation wise, we want to make sure that they're getting oxygen because O2 is a problem here because those cells are being deprived. So we want to make sure that they're not entering into respiratory failure. So they may need intubation, mechanical ventilation, placed on oxygen. Circulation wise, are they actively bleeding? They are. You want to hold firm, direct pressure, call rapid response, get someone there to help you fast because you need a team to help you with this patient. In addition, simultaneously, you're going to be doing all this. You're going to be looking at signs and symptoms of adequate perfusion. Is this patient going into hypovolemic shock? So you're going to pull from those signs and symptoms that they are. And very simple, you can look at their skin, cool and clammy, that would be bad. Look at their mental status, how are they acting, what's their blood pressure, their heart rate. Remember, blood pressure will be low, they can be tachycardic, heart rate will be high. Urinary output, what are they putting out, and looking at all those things. In addition, you want to make sure that you have IV access. We need access to that intravascular system so we can give them fluids and drugs, whatever we need to get that cardiac output up, replace that fluid. So you need at least 2 IV sites, and they need to be a large cannula there in those large veins, those antecubital veins, the ACs. At least 18 gauge or higher. You're going to be giving rapid fluids, fast, and other medications, so we want to make sure that they're nice and working. In addition, they may need a Foley catheter so you can monitor that urinary output precisely, collect that instead of depending on the patient to use the bathroom, which they're probably going to be so sick they can't do that, and we want to be able to collect that. And many patients who have severe hypovolemic shock, they're not responding to the fluids. We're going to have central lines, hemodynamic monitoring, which will help us monitor the cardiac output and how well we're replacing those fluids. And we can look at some numbers. So whenever you have a patient in hypovolemic shock, severe hypovolemic shock, how again is that central venous pressure going to be? It's going to be low. How's that pulmonary capillary wedge pressure going to be? It's going to be low. But we're giving them fluids. So one thing, whenever you give fluids, you have to make sure you're not giving them too much, where we're going to actually flip them into cardiac fluid overload. So if we were giving them too much fluid, how would those numbers start presenting? Central venous pressure can start becoming elevated. The pulmonary capillary wedge pressure can start becoming elevated as well, because putting too much fluid in the heart, it's too much, so it's increasing the pressure over here, or right atrium, so CVP pressure, and the filling pressure in the left atrium for pulmonary capillary wedge pressure. So you want to look at those things. Now, position-wise, what's a good position for these patients? We want a position that's going to increase cardiac output, venous return to the heart. So one position is modified Trendelenburg. This is where the patient is supine with their feet/legs elevated at that 45 degrees. Doing that is going to increase venous return and help us increase cardiac output a bit. Lab-wise, we have to monitor what's going on with the patient, so physicians will be ordering this, and we'll want to be either collecting that, looking at those labs coming out. Hemoglobin, hematocrit, looking, does this patient need blood products? Depends on protocols, but usually less than 8 to 7 for hemoglobin. They'll need some blood transfusions. ABGs, arterial blood gases. Remember, these patients can go into acidotic conditions. We want to be looking at that. Looking at lactate levels, because our cells are switching from aerobic to anaerobic. We're going to get the buildup of lactic acid. Livers may not be working, building up more toxins, or kidneys. Looking at electrolytes, CBCs, looking at BUN, creatinine, telling us our renal function. Now let's talk about our fluid types used for the treatment of hypovolemic shock. Okay, first thing we're going to talk about are crystalloids and colloid solutions. These are 2 types of volume expanders used for hypovolemic shock, and again, this varies depending on the patient's status, volume loss of what will be used. So first let's talk about crystalloids. Okay, crystalloids. What is a crystalloid? Well, normal saline or lactated ringers, and how they work is that they add more fluid to the intravascular system, and this is going to increase preload because it will increase how much fluid's coming back to the heart, and stroke volume and the cardiac output. So with this, you have to watch for fluid volume overload, like I was talking about earlier. And you can look for many things just simply listening to their lungs. You hear fluid in the lungs with crackles. They having difficulty breathing? Are they having elevated CVP pressures or pulmonary wedge capillary pressures? Or just looking for edema in legs, or do they have jugular venous distension? Things like that can point to that they're retaining too much of the fluid. And one thing about crystalloid solutions I want you to remember is that these solutions are able to diffuse through the capillary wall. So less fluid remains in the intravascular system compared to colloid solutions. Now, normal saline or lactated ringers are most commonly used. Number one, they're really cheap, easy to access. And how they're given is by remembering the 3-to-1 rule. And what this rule says is for every ml of approximate blood loss, 3 mLs of a crystalloid solution is given. So let's say a patient has lost 750 mLs of blood. How much of a crystalloid solution would they give? Well, according to that rule, it would be 2,250 mLs because we're going to be giving 3 mLs of a crystalloid solution for every ml of blood lost. Another fluid type is colloids, and an example of this is like albumin or head of starch. And what colloids are, they consist of large molecules, examples like proteins, that can't diffuse through a capillary wall. So in the long term, more fluid stays in that intravascular system for a longer period of time compared to those crystalloids. However, colloids are more expensive to use and patients can have anaphylactic reactions. So again, just with crystalloid solutions as well, you would want to monitor for fluid overload. Now, as a nurse, it's really important to remember if you are giving large amounts of fluids like these crystalloids, colloids, it's very important that you warm them before giving them, because this will prevent hypothermia. And we don't want a patient to go into hypothermia because hypothermia alters the way clotting enzymes work. So we want to keep the patient warm, keep the fluids warm, but we don't want the patient sweating. So remember that whenever you're giving large amounts of fluids. The last fluid type we're going to talk about, of course, is blood and blood products. This can include packed red blood cells, platelets, or fresh frozen plasma. Now, packed red blood cells are going to help replace the fluid that has been lost, and it's going to do another thing that really our crystalloids and colloids couldn't do. It's going to provide the patient with hemoglobin, and hemoglobin will carry oxygen to those deprived cells. So that is one benefit of that. Now, it may be used when the patient is not responding to crystalloid fluid challenge, has experienced severe bleeding, or severe hypovolemic shock. And some other type of blood products used are like platelets, and these would be used for patients who are having uncontrolled bleeding due to thrombocytopenia, so they need some platelets to help with that. Also, fresh frozen plasma. This is for when patients need clotting factors. Now, anytime you're giving any type of blood products, you always want to monitor for transfusion reactions with these products. And I have a whole video on the nurse's role with blood transfusions if you want to check that out as well. Now let's review intake and output. First, let's start out talking about intake. Okay, what does this include? This includes fluids taken in the body. So this can be via the mouth, a tube, or an IV or central line. But first, let's talk about liquids consumed, taken in by the mouth. Okay, this includes any liquids that are liquid at room temperature. That's what we're going to include in our calculation. So this will include things like juice, water, ice chips, and things you want to remember about ice chips is that they melt to half their volume. So if you give them 8 ounces of ice chips, you're going to really record it as 4 ounces because it's going to melt down to 4 ounces. Any drinks like tea, coffee, soda you will include, gelatin desserts like Jell-O, milk, broths, ice cream, frozen treats like popsicles, sorbet, and nutrition supplements like Ensure or Boost. Now, what about pudding? Do you include that in the calculation or not? Unfortunately, the consensus on this is not the same across the board. I will say no, you don't include pudding. I've never included it as a nurse, wasn't taught to. And the latest NCLEX guide by Kaplan says that you don't include pudding in the calculation because it's a semi-liquid. However, some students I've talked to, they said that their professor told them to or their book told them to. So if you have any doubts or questions, always ask your professor before the exam and go by what they tell you. But for this video, we're not going to include pudding when we work our practice problems. Okay, some other miscellaneous things that's included in this intake calculation are tube feedings, like the tube feeding that you would feed them through their PEG tube, whatever type of tube they have. Also, don't forget the free water flushes that they'll receive as well. And any type of IV fluids, central line fluids. This can include TPN, lipids, blood products, any med infusions or flushes. And next, IV flushes, don't forget those. And any irrigants like continuous bladder irrigation, things like that. Now let's talk about output. Okay, this is anything that's taken out of the body that leaves the body. And majority of your calculation for output will be urine. And it also includes things like emesis, vomit, liquid stool like diarrhea, or from an ostomy bag, especially in ileostomy, since those stools tend to be a lot more liquid. Any wound drainage that you can measure, that's like in a drain, like a wound bag, JP drain, a tube, chest tube, anything like that. Suction, that you can suction from the respiratory system, gastric system, you'll want to include. Now, one thing that we don't include but you want to be aware of it as a nurse is the insensible loss, things we really can't measure. And this comes from the skin or the lungs. And according to Mosby's Medical Dictionary, you can lose about 600 milliliters per day through these routes. So whenever you are assessing those I's and O's, you want to take that into consideration. Because remember, if that intake is less than that output, or the output is more than the intake, there is a risk of dehydration on your patient's part because they're losing so much fluid more than they're taking in. Compared to if the intake was more than the output, or another way of saying it, the output's less than the intake, they're retaining fluid. They're at risk for fluid overload because they're just ingesting or receiving all this fluid, but they're not really urinating it out, so they're at risk for retaining it. Now let's solve a problem. Okay, this particular problem wants to know what's the patient's total intake during your 12-hour shift. So whenever you look at these problems, you got to pay attention to a couple things because they try to throw you off. Okay, number one, you have to make sure you're including the right thing in your intake calculation, which is why we went over that whole list of what's included. Number two, a lot of problems will give you the intake in ounces, and you have to convert that to milliliters because we record intake and output in milliliters. And it's really easy how you do that. You take all the ounces and you multiply that by 30, and that will equal your milliliters. Another thing is that you want to make sure you pay attention whenever you are adding up those ounces, and don't add in like 10 cc's to your ounce calculation until you have converted it, because it can throw off your numbers. So let's see what our problem says. Okay, at 8 o'clock our patient had 8 ounces of orange juice, which we will include orange juice. They had 6 ounces of yogurt, we don't include that, and they had a 10 cc IV flush. Now cc's and milliliters are the same. They equal 1 cc equals 1 milliliter. So we're going to include that. So to help me keep them organized, I'm going to have their own little columns, which also equals milliliters. So we had 8 ounces of orange juice and we had a 10 cc flush. Okay, at 10 o'clock they had 8 ounces of coffee, which we'll include, with 1 ounce of cream. Liquid creamers we include, so we'll include that. So 8 and 1. Okay, at 12 they had 12 ounces of soda, which we'll include. They had 2 12-ounce popsicles. Don't let that mess you up. They had 2 of them, so what would it be? We're not going to record 12, we're going to record 24. So 24 ounces. They had 3 ounces of pudding, which we're not including, and then they had 4 ounces of broth, which we include. And then at 1300, they had 6 ounces of soda, which we include. And then at 1600, they had 8 ounces of ice chips. Now, what did we say about ice chips? We only record it in half because it will melt down to that. So we'll record that as 4. And then the last part, it says from 1400 to 1900, they had IV fluids running at 50 cc's an hour, so 50 milliliters an hour. So they had this running for 5 hours. So 50 times 5 equals what? 250. Okay. Now we're ready to add. Okay, so we're going to add up all of our ounces. So all that added together equals 67. But we're still in ounces and we got to get to milliliters. So we'll multiply 67 by 30 and that equals 2010. Okay, now we have to work this part over here. So 10 plus 250 equals 260. Okay, and then we add it all together. So 2010 plus 260 equals 2,270 milliliters, and that was their total intake for your shift. Now let's calculate output. Okay, this problem may be something similar that you may see on an exam, and it says a patient had a TERP and is receiving continuous bladder irrigation. During your 12-hour shift, the patient's Foley collects 5,320 milliliters. The patient received 2,500 milliliters of bladder irrigation. What is the patient's urinary output? Now, whenever you look at this at first, it's like, I don't know. They had all this fluid of irrigation going to their bladder and it's mixed with their urine, so what exactly is their true urinary output? And it's so easy to solve. So what you'll do is you'll take the whole amount that was collected in that Foley bag, because remember in the Foley bag it has urine and irrigation solution in it, so it was a total of 5,320. And then you're going to subtract how much of bladder irrigation was instilled in that bladder. So subtract 2,500. And what do you get? You get 2,820 milliliters. So that is the patient's true urinary output.